Good morning, students, and welcome to your continuing ophthalmology lecture video sessions. Today we will be talking about cataract, and this is our second differential in the theme of gradual painless loss of vision. This is what we are going to be doing today. We'll start off with the structure of the lens, move on to classification of cataracts, how do patients present, how do we manage cataracts, an overview of principles of surgery, plus some videos to ensure that your online teaching is complete, and then some complications that you would expect to see if you're sitting in a family physician's or a general practitioner's clinic. So we'll start off with the structure of the lens first, and this is how the lens appears when you're looking at an eye using a torch, and this is the lens that you see through the pupil. So this is the lens as it is visible through the pupil, and it has a very characteristic grayish-green color. We'll talk more about that just in a bit. And this lens is held in place by zonules, which are also called suspensory ligaments, which are attached from the lens all the way to the ciliary body. So if I bring up this animation, again, this is the lens, this is the iris, and if I remove the iris, we'll start seeing the zonules. These are the zonules. This is the lens. You only see a bit or a portion of the lens through the pupil, not all of it, because most of the lens is covered by the iris. But if I remove the iris, you can see all of the lens. And these are your zonules or suspensory ligaments, which are holding the lens in place. So if I bring up some markers, so this is the lens, these are the zonules, and the zonules attach to the lens and to the ciliary body. Now let's look at it from a posterior aspect. Obviously this is the interior aspect, looking at it from the front, so we'll chop the eyeball off, and this is looking at it as if you are standing behind the eyeball and you've cut a bit of it out. So this is again the lens, these are the zonules, and this brown bit from here to here is your ciliary body to which your zonules are attached. This is the lens, these are the zonules, and this is the ciliary body. This is the gross structure of the lens, and the lens is composed of or consists of an acellular capsule. Just below the capsule on the anterior aspect, we have the lens epithelium, which continues all the way to the equator, which is right here. Remember, equator is the largest diameter. The posterior aspect of the lens does not have this epithelium underneath the capsule. Then we have the cortex. The cortex is actually the growing zone of the lens. This is the area where the lens epithelial cells or the lens epithelium has evolved and formed the lens fibers, which is the structure that the cortex is made up of. The older lens fibers eventually go on and form an amorphous mass, which is basically the nucleus, and as a person grows older, the nucleus goes under a form of compaction because new fibers are added to it, and it gets compact and hard, and also increases in its optical density and also its refractive index. This also means because the cells, the epithelial cells continue to transform into lens fiber cells, that as long as you're alive, your lens keeps on growing and increasing in size, largely to an increase in size in cortex and also to an extent the nucleus. If we look at a more microscopic structure, this is the anterior lens capsule, underneath which we have the lens epithelium, which you can see continues all the way up to the equator, but not underneath the posterior aspect of the lens capsule. And here you can see the lens epithelial cells transforming into lens fibers in the cortical zone of the lens, and these lens fibers have a U-shaped or a bow-shaped appearance. We'll just see that in the next picture. And this is a cross-sectional appearance of the lens fiber cells in the cortex. And as you can see, as we have newer fibers forming in the cortex, the older fibers sort of start degenerating, and they add to the nucleus, and the nucleus over time undergoes compaction and hardness because new fibers are added to it, and keeps getting harder and keeps getting compacted and compacted. This is the picture I was talking about, and this is the cortex of the lens, and as you can see, these lens fibers take on a U-shaped or a bow shape, and as these fibers meet each other from the various directions that they're coming together, remember the lens is a three-dimensional structure, so you have cortical fibers that are coming from the various directions, and they have to interact or meet each other at some point, and that point is called the suture. And as you can see in this diagram, this is where that suture is, Suture is a meeting place, like you have sutures amongst your bones of the skull, you have sutures where your cortical fibers meet each other, and this suture happens to take the shape of the letter Y, as you can see in this picture here. And because you have multiple zones of cortical fibers meeting each other, this suture has a rather complex arrangement. As you can see, this suture plane would form amongst all the cortical fibers as they meet each other. So this is just one of the areas within the lens where the cortical fibers are sort of interdigitating with one another. You can say that this is maybe just this area right here, and they form these sutures which have Y shape to it. Moving on, so this is how your lens appears when you are doing a torch examination or a slit lamp examination. And the most important thing that I want you to see here is the color of the lens. The first thing you need to identify which is the lens. So this is the lens. This is not the lens. This is the iris. This is the lens, and the lens is visible through the pupil. The pupil is the opening in the iris, and you see a bit of the lens as we saw before. Most of the lens is covered by the iris. So this is the lens, and the color of the lens, this is a normal lens with no abnormality in it. It's a clear lens, and it has a grayish green color. It has a grayish green color because it reflects a bit of light back. It gives it that grayish green color. So this is the lens. This is the iris. Don't confuse the iris with the lens. This is the lens. It's not black, it's grayish green. So let's talk about what we are here to talk about, cataracts. And a cataract basically has been traditionally defined as an opacity in the lens. And basically the word cataract comes from water that flows off an edge of a cliff and it sort of mixes with air and gets this white color. And a more appropriate definition of cataract is a change in color of the lens. We'll see why that is in a bit. And most of the cataracts that you will see tend to develop. By develop, I mean they would sort of increase in their size. And as you will see, the lens, and as we have already talked about, the lens has different zones. It has a cortex, it has a nucleus. So you could have a cataract in one zone, for example, in the cortex, and it could just keep on increasing in the cortex. But what happens most of the time is a cataract might start in one area, for example, the cortex, and as you grow older, it involves the nucleus, and so that you have multiple types of multiple zones within the lens becoming opaque or changing their color. Eventually a time would come when all of these structures within the lens have changed their color, and that is something that we call a mature cataract. We'll talk about it in a bit. Cataract is the most common cause of reversible blindness in the world, which is good because the blindness is reversible, and cataract surgery is one of the relatively easier surgeries that is performed, simply because there's not a lot of anatomy and not a lot of vasculature that you have to worry about. It is a little expensive because of the equipment involved. You need a microscope and a special machine to do cataract surgery, but the surgery itself does not take that much time. Usually you do not need special types of general anesthesia, and the anatomy is rather easy. So once you are trained, cataract surgery is rather one of the simplest surgeries, major surgical procedures, you might say, that you can do, considering not only eye, but all of the surgical specialties in medicine. So you look at a cataract, you can look at a cataract either using a torch or an ophthalmoscope. If you're using a torch, the cataract appears white, like shown here. It appears white because the light from the torch is reflected off the cataract and comes to your eye. So this is the patient's eye, this is your eye, this is the torch. So this is the cataract right here. Light from the torch reflects off the cataract, comes to your eye, you get a white reflex. So this is a change in color of the opacity. When you're doing ophthalmoscopy, the cataract appears black, and that is because ophthalmoscopy, the type of ophthalmoscopy you do to look at a cataract, is called distant ophthalmoscopy. So the patient is about a meter away from you. This is your eye, and you're looking through an ophthalmoscope. I'm sure you know what an ophthalmoscope is, and I'm sure you've at least held it in your hand once. So the ophthalmoscope works on the principle of showing you the red reflex. And what happens is that as you are looking through the ophthalmoscope into the patient's eye, as the light is reflected back from the patient's retina, that reflected light is obstructed by the cataract. So it doesn't reach your eye, so you see black because no light is getting to your eye. So on torch examinations, cataract appear white. On ophthalmoscopic examinations, cataract appear black. So we have done the structure bit of the lens. Let's talk about, and we have talked about the definition of the lens. Now we are going to talk about the classification of cataract. There are various means of classifying cataracts, and as you can see here, from when did it develop, was it congenital or acquired, how much of the lens is opaque. Remember I said you have various zones in the lens, and you could have one zone involved, and over time the entire lens might become opaque. And morphology is again which part of the lens has the cataract, and finally, why did the cataract develop? Was there a cause behind it, or is it simply an aging phenomenon? So the other thing that is, you don't, and usually this is the case, that you don't just use one classification system, you use multiple systems. For example, you can call a secondary cortical cataract. That would be secondary from mode and cortical from morphology. We'll talk about what secondary and cortical is just in a bit. You can also use one from onset, acquired, and then another from morphology, posterior subcapsular. So there are, you usually use multiple systems when you're defining a cataract. Obviously, there are some combinations that simply don't work. You cannot have a mature nuclear cataract, because a mature cataract implies that all of the structures within the lens, the cortex, the nucleus, etc., they're all opaque. So you can't have a mature nuclear cataract. You have a mature cataract, that would mean all of the lens is opaque. So certain combinations don't work, and it's pretty much common sense things. It's not something that would require rocket science to understand, once obviously you have done the morphology. So we'll start off from the first one, which is onset. When did the cataract develop? And it could be congenital or acquired. Congenital cataracts are those that are usually diagnosed at birth. Those that are diagnosed by 1 year of age from birth are usually called infantile cataracts. The good part is, although you see cataracts, congenital cataracts, most of these congenital cataracts are not visually significant, so they're not going to affect vision. If they are visually significant and they're not removed at an appropriate time, they can lead to amblyopia. And we've already talked about one type of amblyopia that was occurring if you have a difference in refractive error between the two eyes. This amblyopia would occur because, again, you have a young child between the same age groups up to maybe 12 years of age. And this time there is not enough light reaching the retina. So this is called vision deprivation or sensory amblyopia now. The first time the cortical pathways were shutting down because there was a difference in refractive error, one eye was producing a blur image. This time the cataract is blocking the light from reaching the retina, so one eye is generating no image. So again, the cortical inhibition occurs, which causes amblyopia. And this type of amblyopia is called vision deprivation or sensory amblyopia. Generally, they can be unilateral or bilateral congenital cataracts. Unilateral are those that are sporadic and they just occur. There is no real identifiable cause. A bilateral congenital cataract is associated with metabolic disorders, intrauterine infections, gene mutations, and some of them are listed here. Hypoglycemia and diabetes both can damage the lens. Trisomy, which is Edwards syndrome, Down syndrome, Tau syndrome. I'm sure you have done these when you were doing embryology and also when you were doing or will do pediatrics. Myotonic dystrophy, infectious diseases, especially these torch infections, which is toxoplasmosis, rubella, cytomegalovirus, and herpes. Again, these are something that develop in, or these infections are intrauterine. And prematurity. So the important thing here to remember is that usually unilateral cataract are sporadic. There is no identifiable cause, but bilateral cataracts, if you see an individual, you should always try and figure out why they develop, because there is almost, in most cases, an underlying etiology or a pathology that can be picked up. So unilateral cataracts, unknown etiology, sporadic. Bilateral are usually of a known etiology, as we've just talked about. And as I said, most of the time they are visually insignificant, but they can be visually significant. For example, this is a nuclear cataract because the nucleus is opaque and the cortex is clear. And this is visually significant as compared to this, which is a, what would this cataract be? What does this shape look like? It looks like a Y. So this is a cataract only in the area of the sutures where the cortical fibers meet. So this is something that's going to be visually insignificant simply because though it is very central, but it's too small to cause significant visual issues. So this does not lead to amblyopia or significant visual loss, while this would cause amblyopia and significant visual loss. This is another type of congenital cataract. It's called a blue dot cataract. You have multiple opacities in the cortical area. Again, this is visually insignificant. This is a differential diagnosis of a white pupillary reflection or white pupillary reflex or leukocoria. And this includes cataract, because when you see cataract with a torch, you get a white pupillary reflex or leukocoria. So this, in fact, is a differential diagnosis of a congenital cataract. Congenital cataracts are peculiar. They are peculiar because A, your patient is a child who cannot directly communicate with you, and the person communicating with you is the parent or the guardian. And they say, this child cannot recognize familiar faces, bumps into things, is always trying to grasp light, has this really wandering gaze, all of the things that a child who cannot see properly. So they're going to be saying all of these things. And the child cannot directly communicate with you because he can't. He's at an age where he can't tell what he is experiencing himself or herself. And in addition to cataract, we have these diseases that also present with a white pupillary reflex. And this is important because all you have in that child are signs you can pick up, because you can't directly communicate with the child. You have clues in the form of signs. The other thing is that these diseases, that the ones that are listed here, these children are going to be in a very similar sort of an age bracket. Obviously, not all of them are going to be at the same age, but a very similar age bracket. And when these conditions start, the child is usually in a pre-verbal state. He cannot talk himself or communicate effectively himself. He can just express inability to see properly. And some of these conditions are really dangerous. For example, retinoblastoma is life-threatening in addition to being sight-threatening. So it is important to keep in mind these conditions when you're looking at a child who produces or who presents with, not produces, presents with a white pupillary reflex. Do not think it's a cataract only. Think of other things. One thing that sort of simplifies excluding cataract from this list is comparing a torch reflex to an ophthalmoscopic reflex of a cataract. On ophthalmoscopy, cataracts appear black, while on torch examinations, cataracts appear white. We have talked about this. In fact, that's true for all cataracts, not only congenital cataracts. But it does not mean that you can exclude other conditions simply on the basis of this fact. So when you see a white pupillary reflex on a torch examination, you have to keep these things in mind. We will talk about them, most of these diseases, when we talk about retinoblastoma. That's towards the end of the clerkship. The reason we are doing that is by the time we get there, we could have talked about some more of these conditions so that we can have a nice summation there. The reason for putting this differential here is because this differential of a congenital cataract is different from the differential of an adult cataract. Simply because for adult cataracts, we have the theme of gradual painless loss of vision, and all the 5 conditions that we list there are for an adult cataract. It does not mean that adults don't present with white pupillary reflex. They do, but their differential is different because these conditions listed here are those that present at a pediatric age. Obviously, some of these conditions like rhegmatagenous retinal detachment can happen, and mostly does happen in adults, but retinopathy of prematurity, Coats disease, persistent fetal vasculature, retinoblastoma are sort of exclusively in a pediatric age. Coats disease can present later in an acquired form, but congenital Coats disease, which is specifically what Coats disease is a congenital malformation of vessels, which also generates a white pupillary reflex. So the reason for putting this slide here is simply to tell you that this is a differential of a white pupillary reflex in a pediatric age group. Do not use this when you are talking about an adult. Only use this differential when we talk about congenital cataracts. This is a differential of a congenital cataract, i.e. white pupillary reflex or leukocoria in a pediatric age group. Not adults, pediatric age group differential. Adult differential is what we have talked about before. This is not a differential of gradual painless loss of vision. This is a differential of white pupillary reflex, and cataracts do generate a white pupillary reflex. This is a differential based on signs, not on symptoms. Our themes are symptomatic, and because children cannot communicate by themselves, we are reliant on signs for differentials, and this sign of white pupillary reflex in a child can be because of any one of these diseases. So when we talk about children, white pupillary reflex, think these diseases. All right, thank you. So now we are moving on to the onset number 2, which is acquired. Acquired can be either primary. Primary is something in which we don't have an identifiable cause of cataract. These are the most common types of cataract that you see, and they can be pre-senile, less than 49 years of age, or senile, more than 49, which is the most common type of a primary cataract. If you do see a pre-senile cataract and you investigate really well, you can usually find a cause, and that then would become a secondary cataract, a cataract that has an identifiable cause, which could be an ocular disease, a systemic disease, some drugs, trauma to the eye, or deposition of some drugs as well. We'll talk more about primary and secondary type when we talk about the mode system of classification. Now we are moving on to opacification. This is basically a change in the amount of opacification or color change over time. So this is something that you can take as chronological, a small cataract becoming into something that is involving all of the lens, and then also developing beyond it, as you will see. So cataracts begin usually in an immature form. By immature, we mean that the cataract is in a part of a lens, but is not involving all of the lens. So when you do ophthalmoscopy, you will have some blockage of the red reflex, but you will also be able to see the red reflex. You see some blockage because the area where the cataract is, you'll see black, but the area with no cataract, you will see red. So an immature cataract is one in which there are areas within the lens which are normal and clear, but there are areas which have changed their color or developed in opacity. So this is how you would see an immature cataract on ophthalmoscopy, and really it is ophthalmoscopy that helps you define cataract based on their opacification, and this is how you would see it on a torch. Again, cataracts appear white on a torch and black on ophthalmoscopy. You can go back to the slide where we talked about this for more explanation. From immature cataract, we move on to a mature stage and then to a hypermature stage. Both of them appear the same when you do ophthalmoscopy. Mature would mean because all of these lens structures are now opaque. There is no clear zone in the lens, so you don't see any lens red reflex when you're doing ophthalmoscopy. This is how it would appear on a torch. A hypermature cataract is one in which the cortex has now started to degenerate prematurely. Remember, cortical fibers degenerate over time, but now they have started degenerating prematurely. And why that is happening is because, remember, as you are growing older, the lens is increasing in size. And there will come a time when the lens capsule is fully stretched. So what I'm going to do is bring up a little animation here to explain this. And this is the lens of, let's say, a 45-year-old or a 40-year-old person. You have this cortex and nucleus, and as you grow older, what would happen is that this capsule would reach a maximum stretch as you're growing older. So now imagine that this person is about 70 years of age, and this capsule is stretched to the maximum limit. It can't stretch anymore because of the increasing size of the nucleus. So if the capsule can't stretch and the nucleus is already a hard structure, it's amorphous, it's all the old fibers that have died. So what's going to happen to the cortex in between? It's going to get squashed. It has a fully stretched capsule that won't stretch anymore. And the nucleus right here, this nucleus is hard. So this cortex in between is under a lot of stress. So what would happen is that these cortical fibers would start degenerating because they're under a lot of pressure. From a capsule that doesn't want to stretch anymore, and from a nucleus that's already hard. Imagine sitting on a middle seat of an aircraft or a bus, and you have two really hefty people on either side, and they're just squeezing you. This is what's happening here. So this cortex is going to turn into liquid, or it will degenerate and it would become liquidy. And as it degenerates, the stretch on the capsule would reduce because the size of or the thickness of the cortex is now decreasing because the cortex has started degenerating. So that stretch you had on the capsule is gone, and you start seeing wrinkles on the capsular surface, which I have highlighted here with these lines. If I remove these lines, these are how the wrinkles would appear, and these are the wrinkles that I have sort of highlighted to show you how they would appear. And these wrinkles are appearing because the capsule has lost the stretch that was on it, and that's because the cortex has started to degenerate and becomes liquefying. There is a special type of a hypermature cataract which is called a Morgagnonian cataract. A Morganian cataract is an evolution of hypermature cataract in which all of the cortex has turned liquid and it rises because it is less dense as compared to the nucleus, which sort of sinks to the bottom. Obviously, all of this is still happening within the capsular bag. Nothing has gotten out of the capsule yet. So we started off with immature cataract. With time, it developed into a mature cataract, and over beyond that time, it turns into a hypermature cataract, and over beyond that time, it turns into a Morganian cataract. How much time it takes to get from immature to mature is very difficult to say. I've been following patients for 10, 12 years who are still immature. I've seen patients who go from immature to mature in about a year or less, especially if they have a systemic disease like diabetes, which can accelerate cataract production of cataract within the lens, as well as progression of cataract. There are two more classifications or two more stages in this. There is a special type of immature cataract which is called an incipient cataract. An incipient cataract is a type of immature cataract that would have no effect on vision. And it can have no effect on vision either because it's very, 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 very small, or the cataract is in an area which is normally behind the iris. Remember when we saw the torch examination picture, we said that the bit of the lens that's visible to you is visible through the pupil. An area of the lens is hidden because it's behind the iris. You see more of the lens here because the pupils are dilated. So an immature cataract that has no effect on vision, either because the cataract is very small or it's off visual axis, it is behind the iris, it would have no effect on vision. It's an incipient cataract. Its appearance, if you could see it, would exactly be like that of an immature cataract, but you have to be able to see it. If it's hidden behind the iris, you won't be able to see it unless obviously you dilate the pupil. There is a special type of a mature cataract as well, which is called an intumescent cataract. An intumescent cataract is a mature cataract that has imbibed a lot of water. With time, as the size of the nucleus increases, the osmotic pressure within the lens increases, and it starts taking up a lot of water, so it swells up and it becomes intumescent. An intumescent cataract would appear exactly like a mature cataract on distant ophthalmoscopy, simply because both of them are obstructing the entire red reflex. It's just that the capsule appears to be very, very stretched and glistening simply because it's imbibing water and it's under a lot of stretch. You know, if you have a lot of fat under your skin, it's also nice and glowy. So imagine that this lens is all fat because it's imbibed water, so it's nice and glowy and shiny. These two stages, incipient and intumescent, are sort of, in between. Incipient cataracts are just, telling you, yeah, you have a cataract. It's not visually, it's not affecting your vision at all. Immature cataract is one, yeah, you have a cataract and it's affecting your vision a little bit. Intumescent cataract is telling you that now your cataract has become so big and so thick it starts taking up water. So they have their place, but honestly, immature, mature to hypermature to Morganian is something that's more commonly used. But there are two other stages and we mentioned them here. So this is how a cataract involves. No cataract to immature cataract, which could be of an incipient variety, to a mature cataract, which can become intumescent with time unless it's taken out before, which will become hypermature, and then it can go into a Morganian state. Now we are coming on to a relatively more important classification system, which is morphology. Morphology, i.e. where is the cataract within the lens, can actually at times tell you why did the cataract develop, so you can have a hint into a secondary cause. So we'll start off obviously from the interior structure and then move accordingly. We'll talk about the capsule first, then the cortex, and then the nucleus. So this is basically anterior capsular and subcapsular cataracts, and they are usually of the secondary type, and they are usually either because of some drug depositing in the lens, or some inflammation within the eye, or trauma to the eye. So the first two ones, A and B, they are both drug deposition: chlorpromazine, antipsychotic; amiodarone, which is an antiarrhythmic drug. This one produces a star shape or a stellate cataract. This one produces this generalized hazy deposition. And C is because of high pressure within the eye, because of angle closure. This one is called glaucoma fleck, and we'll come back to this when we talk about the mode part of classification system. And unless traumatic, most of these are visually not significant, and the reason they form is it's theorized to be that the epithelial cells, remember the epithelial cells are below the anterior capsule, they turn into myofibroblasts and they lay down opaque fibers. So that's why you get these cataracts, or it could simply be a drug deposition within the lens. This is posterior subcapsular. So we have talked about the anterior capsule. Let's talk about the posterior capsule. This is a posterior subcapsular cataract. This is the view on the torch. This is the view on the ophthalmoscope. These white arrows are basically right reflexes. Posterior subcapsular cataract gives you a very strong hint that your patient might be on some form of steroid intake for a long time, or he could also be, for example, have diabetes. It's also a part of aging, but seeing a posterior subcapsular cataract should always alert you to the possibility that your patient is taking steroids or your patient is a diabetic. And it's not that difficult to recognize posterior subcapsular cataracts, because anterior capsular cataracts and subcapsular are very rare, because drug depositions would take time. Trauma is something that would be an extraordinary event. So is intraocular inflammation. It's much more commoner to have diabetes and to be taking steroids, because in Pakistan, especially topical steroids are available off the counter when they should not be, and they're prescribed like people eat. What do they eat in Pakistan a lot? Biryani. And they put steroids in their eyes, because putting a drop of steroid clears your eye up and it makes it look very fresh. So people use steroids, and there are a lot of commercial preparations which might seem innocuous and harmless, and they might actually contain steroids, rose water, for example. So these are some things that you really need to be careful of. We will come back to steroid intake when we talk about, again, mode of cataract, but a posterior subcapsular cataract should definitely alert you to steroid intake or diabetes. And if you can't really find anything, and it's very easy, just ask a question and do test for diabetes, HbA1c, BSR, BSF. And they're called posterior subcapsular because they are in the subcapsular area, and these form because of fibroblast transformation of lens fibers if you're taking steroids, or simply because in diabetes you have a lot of sorbitol accumulation. So because of that sorbitol accumulation, you have increased osmotic pressure, which causes hydration, which causes cataract formation. And this posterior subcapsular type of cataract produces very characteristic near vision loss, and even more loss of vision in bright light. When I talk about loss of vision, obviously there's this general decrease in vision, but this decrease in vision is accentuated, especially for near vision and in brightly lit areas. And if it's not that difficult to understand why, especially if you have a very good grasp of your structure and function of the special senses. Just think what happens when you look for near, and we did this only a couple of days ago or yesterday even, and near reflex, if you remember, did three things: lens accommodation, convergence, and something else, and that something else explains this. And what basically happens is that in both of these, when you have a when you're in a brightly lit environment, or you have a change in illumination, your pupil becomes small. It constricts in response to increased light. The same thing happens when you have near reflex, in which you have lens accommodation, pupillary constriction, and convergence. So that pupillary constriction would imply that your pupil is so small, or has become small enough, that the only visible part of the lens is the one in which you have this cataract. So it blocks most of the light going through. Thus, you have problems. And the biggest problem that these individuals have would say, when I'm driving at night and there's another car approaching from the other side, and if I just mistakenly, even for a split second, look at that car, I go blind, especially if you have a cataract, and if that person has a cataract in both eyes, because his or her pupils would constrict, and you would end up in a situation like this, where the only visible part of the lens is the part with the cataract, because most of these cataracts unfortunately start developing in the visual axis, as you can see right here, and they would cause an immediate loss of vision. So that's something very interesting. And it actually, patients come in and tell you, as soon as I go into a brightly lit area, or if I'm trying to read something, my vision sort of decreases. This is an early posterior subcapsular cataract, and it has evolved to involve the entire posterior subcapsular region. Cortical cataracts are formed in the cortical zone or the cortical region of the lens, obviously, and they are caused by hydration of the lens fibers in the cortex, which are also called the cortical fibers. This type of cataract is strongly associated with diabetes because it is sorbitol accumulation within lens fibers, and that causes a change in osmotic gradient, which causes hydration. It is also associated with aging, and is associated with aging because of deposition of crystallins or accumulation of crystallins. Crystallins are lens proteins. There are various types, which are beyond the scope of an undergraduate study. But suffice to say, because of aging and increased deposition of crystallins, again, the osmotic gradient changes, which causes hydration, which causes a cortical cataract. And they appear like spokes of a wheel. They appear like spokes of a wheel because remember, cortical fibers are bow-shaped or U-shaped. I'll just show you a picture. This is how cortical fibers appear. This is the lens epithelium, and remember that the lens epithelium transforms into a lens fiber in the cortical zone, which is also called a cortical fiber. And these fibers are, as you can see, bow-shaped or U-shaped. Since a part of the lens is behind the iris, we can't see this turn part, but we can see this straight bit. And because this turn part is hidden by the iris and the straight bit is visible through the pupil, so these type of cataracts appears as spokes of a wheel. Let's see how they appear. And this is how they appear, like spokes. You can't see the bent part or the U part because it's hidden behind the iris. This is how they would appear on a slit lamp or a torch, and this is how they appear on distant ophthalmoscopy. One very characteristic feature of a cortical cataract is the patient complains of halos around light. That is because of dispersion of light by these spokes, these cortical opacities. We'll talk more about this again when we are talking about specific types of symptoms that certain cataracts produce. The fourth morphological type of the cataract that we need to go over is the nuclear cataract, and as the person ages, the increase in the nucleus hardness and density, hardness i.e. the compactness of the nucleus and increase in density, results in a nuclear cataract. And the change in definition of a cataract was basically of the way nuclear cataracts occur and evolve. Because of the increasing compactness and the increasing density, initially the nuclear cataracts just undergo a change in their color, and that's it. They still allow light to pass through, and we'll see a consequence of that just in a bit. They're just increasing in their density, which is increasing their refractive index, and then which is thus changing their color. As time passes and the refractive index continues to increase, the color of the nuclear cataract also changes. So from white, they evolve into a really brown color sometimes, which is referred to as a renaissance cataract. And this change in compactness, i.e. hardness and color, is thus termed as a nuclear cataract or nuclear sclerosis cataract, because sclerosis means hardening or stiffness. So this is an early nuclear cataract, and this is a rather good picture. It's taken from a slit lamp. A slit lamp is called a slit lamp because you can form a slit-like beam of light with it. So this is the image of the flash. That's the image of the illuminator. This is the image of the flash. What we are interested are in these lines of light. This light is being reflected off the cornea. This light is being reflected off the anterior surface of the lens. So this space in between is called the anterior chamber, the gap between the cornea and the anterior surface of the lens. This light ray right behind the one coming from the anterior surface or the anterior capsule of the lens is coming from the anterior cortical zone. This is coming off the nucleus, and as you can see, it's white in color. This is what an early nuclear cataract would look like. And finally, this light ray is coming from the posterior capsular area. So if I were to put labels, A is coming from the cornea, B is coming from anterior lens capsule, C is coming from the anterior cortex, D is coming from the nucleus, and E is coming from the posterior lens capsule. This is another picture, again taken from a slit lamp, and this is the nucleus. These are the various light reflections. This is how it would appear on a torch or a slit lamp appearance. This is a slit lamp appearance. This is how it would appear in when doing ophthalmoscopy, and this is more important for us because morphology or this entire grading is easier to pick up. So some of them are easier to pick up using an ophthalmoscope. In fact, the level of opacification is basically defined on the ophthalmoscopic appearance, distant ophthalmoscopic appearance to be more precise. So as you can see here, the dotted yellow line represents the nuclear area which has now gone and developed a cataract, and this clear zone is the cortex. You can see the red reflex clearly passing through this area, the one indicated by in between the dotted line and the boundary of the pupil. This is the light which is illuminating this eye, and as you can see that in the central zone you have an area of darkness where the density has increased to a level where it is preventing light from actually passing from the eye of the patient to your own eye. That is why it sort of appears black. But by and large, this nucleus is allowing a lot of light to pass through. So this is the boundary of the cataract or the nuclear cataract. And as you can see, a lot of red reflects through it. That means this is bouncing off the patient's retina, getting out of the patient's eye into your eye. So a nuclear cataract is allowing a lot of light to get through, which would imply that this is not really an opacity which is obstructing light. And thus the change in definition of a cataract from an opacity to a change in color of a lens. This also has certain important ramifications and implications that we'll just get to in a second. This is how the nuclear cataracts progress over time, and you can see the change in color as you get to a more darker colored cataract. They do start obstructing the passage of light and cause decrease in vision because they have become so dense and so thick that they actually start preventing light from reaching the retina. So this is a rather early nuclear sclerosis. This is later. You can see a change in color from white to sort of yellow. Well, let's see what is going on with our 65-year-old patient here, and this is basically the ramification bit. You have a 65-year-old patient who now says that he can read clearly for near without using his spectacles, and he's come to you because he's surprised and he thinks that he's got his powers back. When he was 40 years of age, his doctor told him that he has become presbyopic. He was emetrope before that, and now all of a sudden the powers he lost are back and he's excited. So he goes to his family physician, which being you in this case, and you were a very good student of ophthalmology, and you tell him, yeah, you have power, but this is not exactly the same power you had before. The power you have now is because of an increasing refractive index of the nucleus within your lens, and obviously you're going to put it in a way that he can understand. So this increase in refractive index of the nucleus within your lens increases the power of the eye so that you can read clearly for near. This is called second sight. You tell your patients or patients if you have more than one with similar complaint that with age the lens in your eye has sort of become harder, which has sort of made it more powerful, which also implies you have a cataract. So this is good right now, but with time maybe this cataract can also obstruct vision. They're usually not bothered at that time by the obstruction bit because that comes later. They're just happy that they can see clearly for near, and this phenomena is called second sight. Together with this, these patients might also experience myopia or myopic refractive error, to be more precise, and that is because if the power of the eye is increasing because of the increasing refractive index of the nucleus, which is basically helping or assisting in near vision, that means that the power of the eye for distant vision has also increased. And if this patient was an emetrope and has gained a certain power after that, when he had this second sight phenomena, the total eye power must be more than 60, because remember you need 64 for comfortable near vision at 25 centimeters or 0.25 meters. So his eye power must be close to that amount, which also means that for distance, now the light rays are focusing in front of the retina, i.e. he has become a myope. They are not usually bothered by this simply because they are at an age where they prefer to sit at home, use a tablet, cell phone, laptop, watch TV, more near vision tasks. So they're happier. My dad went through this about a year ago. He was ecstatic that he can read without his glasses, especially when he goes to a restaurant. He doesn't have to put his glasses on to see the menu or the bill. He's happy right now. He doesn't know what's waiting for him. And obviously, as we have talked about, later nuclear cataracts would affect distant vision also, in the sense that distant and near vision, because they become so dense that they do obstruct passage of light to the retina. Finally, a category that I didn't really list but should not come as a surprise is basically multiple. You could have cataracts starting in various zones or within various structures of the lens. So for example, you could have a cortical cataract together with a posterior subcapsular cataract that's visible in this picture. You could have a nuclear cataract together with a cortical cataract. And there is really no telling, unless you have a specific cause. For example, you're taking steroids, that would cause a posterior subcapsular cataract. It won't cause a cortical cataract. However, a patient who has been taking steroids when he was less than 50 years of age and has developed a posterior subcapsular cataract because of it, he can go on and develop cortical cataract or nuclear cataract because of aging. So you see, you could have a cataract within one specific area within the lens, for example, just a posterior subcapsular cataract, or you could have it in multiple zones, which is more common. And it's very difficult to tell unless you have a specific etiology where the cataract will start. Most of the time it starts in the nucleus because that makes sense because of aging. It can also start in the cortex at the same time as it's starting in the nucleus because of aging. If you're taking steroids, it would start off as a posterior subcapsular cataract. Obviously, if you started steroids at a young age. If you started taking steroid at an old age and you already had nuclear cataract and a cortical cataract, you then would go on to develop a posterior subcapsular cataract. So it is possible to have multiple morphological types of cataract in the same lens of the same eye. And it's also possible that you have cataracts beginning in the all zones simultaneously, and they can also just begin in one zone, for example, posterior subcapsular, as I said, or nuclear because of aging, or cortical because of aging, and then go and involve other zones. There are certain types of cataract that would stick to their zone because of their particular etiology, as in steroid intake. But obviously this patient, if grows old enough, would develop cataracts within other structures of the lens simply because of aging. So this is just a comparison of how different types of cataract appear on a red reflex. This is important because most of the time morphology is determined by looking at the red reflex. So this is something you should be good at, and you will develop this reflex or this ability to recognize once you see enough of them, once you come back for classes. If you are watching this in the time of nCovid 2019. It's called SARS-CoV-19, I think now. Finally, mode. We're getting towards the end of this part of the discussion, and mode is basically, why did the cataract develop? So mode is either primary or secondary. A primary cataract is one in which you don't have an identifiable cause of development of cataract. And this is the most common type of cataract that you see, and it is either a presenile type, when you see in individuals who are less than 49 years of age, or of 49 years of age. And if you investigate for a secondary cause, most of the time you will find one, but you need to be very good at your investigative work. Senile cataracts are those that are seen because of aging, and they are seen in individuals over 49 years of age. And of the primary type, this is the most common type. So a senile primary cataract is the most common type of cataract that you see, and the most common type of senile cataract that you see is a nuclear cataract. So nuclear cataract is the most common type of a primary senile cataract that you see, which is the most common type of cataract. Yes, but obviously it can be of any morphological, and it can be of multiple morphological types depending if the patient has any comorbids, but the most common type you see is nuclear. And as I've said before, it's very difficult to determine how fast these will grow. In some, I've seen patients who have had an immature cataract, a nuclear cataract for ages, or a cortical cataract for ages, and other individuals in which there is, after significant investigative work, you find no cause and you classify it as a primary cataract, and it just sticks around for ages. which is good for the patient because he doesn't have to go through the trauma of surgery, but it's also frustrating for the patient because he keeps saying, why isn't it increasing? Why can't I just, why doesn't it just do what it does and get it over with? Secondary cataracts are those that are secondary to unknown or unidentifiable cause. These types of cataracts are strongly associated with diabetes and steroid intake. As far as diabetes is concerned, cortical and posterior subcapsular types are common. Long-term use of steroids, whether they be inhaled, oral, topical, or taken systemically, are associated with the posterior subcapsular type of cataract. The thing about steroid-induced cataracts is that discontinuing a steroid does not reverse cataract formation. So whatever cataract you have remains there, and at times a cataract continues to progress. The reason that you get a steroid-induced cataract is exactly not known, but it is thought to be a fibrous transformation of the lens epithelial cells. The other associated ocular conditions include, in addition to the two that we have talked about, which are not ocular but systemic. Steroid can be ocular, but the associated ocular conditions include ocular trauma, which causes a very characteristic sunflower-like cataract, which can be seen in blunt trauma and also electrical shocks. Penetrating trauma, on the other hand, causes very rapid hydration of the lens and a very rapid opacification of the entire lens. Intraocular inflammations like angle closure keratitis and uveitis also cause cataract. We'll see how an angle closure associated cataract appears in a bit. You can also get secondary cataract because of drug deposition and chlorpromazine and amiodarone. We have seen both of these types of cataract when we were talking about morphology, specifically anterior capsular and subcapsular cataract. And we also said that these types are usually not visually significant. The progression of these types of cataract, the rate of progression would depend upon how well the underlying condition is managed, if it is managed at all. And obviously, management of these types of cataracts also include managing the underlying conditions. So this is how a traumatic cataract or a sunflower cataract appears. This is torch, this is ophthalmoscope. This is traumatic cataract because of penetrating trauma. This is where the foreign body entered the eye. This line right here is probably showing you how it is traveling or penetrated the lens capsule and is causing opacities in various structures. So there is a definite corneal perforation, and that's just sort of sealed itself, or maybe it was repaired. This is a posterior subcapsular cataract, early, late, and as long as the patient keeps on taking steroids, the posterior subcapsular cataract would increase. Even if you stop it, whatever cataract has formed, it's not going to go away. And if you keep on taking it, it'll increase. In fact, as I've talked about it before, all cataracts progress. The speed of progression varies. This is because of uveitis. The classical feature that tells you this is a uveitis is that irregular and small pupil. This is glaucoma flecken, which is caused because of high pressure within the eye. These are localized focal areas of ischemia of lens, which has led to the change in their color. It's called glaucoma flecken, pressure in eye causing flecks on the lens. So now that we have done structure and classification, we'll talk about how do patients with a cataract present to you. We'll talk about congenital cataracts first, and obviously your baby is not going to tell what's wrong with me. It's the parents or the guardians that are going to say that my child is unable to recognize familiar faces, which would be the face of the mother primarily. My child keeps on searching for light. He's grasping for things, or he's just bumping into objects. He might have history or features of one of the conditions associated with congenital cataract, diabetes, hypoglycemia, Down syndrome. One of the features of intraocular infections, rubella, for example, can cause deafness as well. So that presentation would vary depending if there is a cause. Remember, bilateral usually do have an identifiable cause. It's the unilateral cataracts that are sporadic. Unilateral are also more difficult to detect because unless very, very apparent, they can be sort of obscured from the parents simply because the child keeps looking through the good eye and keeps on doing whatever he wants to do, recognize the mother, recognize where he is going, or grasp objects. And that is actually problematic because unless the parents are very observant or the cataract is really apparent, this cataract can at times cause amblyopia because it might not be seen, but it can be visually significant. So this is something that is very important, and that is where the job of the neonatologist that examines the baby right after birth is so important. So he takes a very good look through the ophthalmoscope to see if he can see a good red reflex. By an ophthalmoscope, it's going to be useful for you throughout your life. Bilateral are sort of easier to detect, not because they have an associated systemic condition, simply because cataracts in both eyes would lead to poor vision if they are visually significant. Adult cataracts are easier, and the patient presentation is a gradual painless loss of vision with visually significant cataracts. Remember, I said not all cataracts are visually significant. Some might be caught on screening when a patient comes in for a change of glasses, or he might have diabetes, or he might have another complaint, and the doctor says, hey, you have a cataract, but it's not visually significant. I'm just letting you know because it's there. The most common is obviously a senile type, and of the senile type is the nuclear type that is more common. And if you have a patient of a secondary cataract, he might have, and he will definitely have a history of one of the other features that cause the cataract. Trauma is going to be apparent. Intraocular inflammation, we will do them, so you'll get to know the history. Systemic conditions you will do as we talk about them in medicine, especially diabetes. But diabetes itself can go on undetected for years because the initial phases are asymptomatic. You need diabetes for a really long time in your body before it actually starts producing ocular symptoms. Primary cataracts tend to be bilateral and asymmetrical. In fact, most of the cataracts are bilateral. Secondary cataracts also can be bilateral and asymmetrical, especially if they're associated with a systemic disease like diabetes or a systemic drug intake, not input. True unilateral cataracts are those that develop if you're putting a drug in one eye, if you have ocular trauma in one eye, or ocular inflammation in one eye. Certain types of cataract do affect vision in more than just reducing visual acuity. We have already talked about how posterior subcapsular cataract causes decreased near vision and decreased vision in bright lights. Cortical cataract, we've already described, produces halos and glares. It's because those cortical spokes cause dispersion of light, as shown in this picture right here. These are the dispersed light, and when they focus on the retina, they produce that little a stimulus on the retina, and all of these stimulating points eventually form that halo around the eye. And nuclear cataracts, while not exactly a complaint, it does bring the patient to you, hey, how can I see without my glasses? So you can call it a sort of a complaint. Now we are going to be starting to talk about a very special type of presentation, and that is a presentation of a cataract that you don't remove in time. So these can be considered to be a complications of an unoperated cataract. And this basically starts off with a mature cataract, and a mature cataract can become so large that it can potentially block the space between the pupil and the lens and the flow of the aqueous, and so the aqueous starts collecting in the lens and causes something called phacomorphic glaucoma. Phaco from lens, morph from change in shape. And this is not a real glaucoma, because as you'll find out when we talk about glaucoma, glaucoma is so much more than just rise in pressure. So this is an antiquated or the old definition which has stuck around. And in fact, most of the most of the terms we use today in reference to glaucoma are from a time when glaucoma was just raised intraocular pressure. But now that is not glaucoma. That hasn't been glaucoma for decades. It's dead, it's buried. These terms have just stuck around because people remembered them, so they just stuck around. Don't ask me why they stuck around. So the first one was phacomorphic glaucoma. The other two complications that you get are because of a Morganian cataract, and these two complications are a rise in pressure. And this rise in pressure is not because of an increased size of a lens. Remember, Morganian cataract has actually become smaller because the cortex has now liquefied. The problem is these proteins, they were always within the lens capsule, and the lens is avascular after birth. Before birth, it has its vasculature, and I'm sure you remember the embryology, but after birth, the normal lens has no vasculature. So these proteins that form the cortex were always hidden from the body, and they were never exposed to the body. So the body never processed these antigens. And when these proteins become liquid, the cortex liquefies, and now it can potentially leak out of the capsule, because first they were sort of proper solid lens fibers, and now they are liquid and they can leak out. And when they leak out, because the body was never exposed to them, they were never processed, it incites a very strong inflammatory reaction within the eye. And in addition to that, these proteins can block the path through which the aqueous escapes the eye, which is called the trabecular meshwork, not the canal of Schlemm. Canal of Schlemm comes after. Before it is the trabecular meshwork. So they block the trabecular meshwork, and when the trabecular meshwork is blocked, the pressure rises. So they can cause a raised IOP. And if the other term used is called secondary open angle glaucoma or phacolytic glaucoma. Again, this was previously called inflammatory glaucoma or phacotoxic glaucoma. Again, all these terms, glaucoma, are from a time when the glaucoma was just a rise in pressure. They've just stuck around because they have stuck around. And as I said, these proteins can also incite a strong inflammatory reaction because they were never exposed to the body. They're all foreign to the body because these antigens were never processed. And this is called phacogenic uveitis, which was at one time called phacotoxic uveitis. Nobody uses the word phacotoxic uveitis or phacotoxic glaucoma. They might be in your books, which haven't been revised for ages, but these terms are not in any modern text that I have ever seen. In fact, even when I was doing my MBBS or my residency, I'd never heard of these terms, phacotoxic glaucoma or phacotoxic uveitis. We used to use phacolytic glaucoma or phacoantigenic uveitis. So these are that old, and I graduated in 2000. I don't know why they stick around in your books, but since students are sort of, very curious and they really want to read books, and that's not wrong, but then the book should revise themselves. So I'm just put these terms here just to make sure that you know what means what. So let's just see diagrammatically what happens. Let's talk about phacomorphic glaucoma first. So the lens has become, mature cataract has become so large that it has blocked this little pathway between the lens and the iris through which the aqueous humor was flowing. Aqueous humor is produced from the ciliary body right here, flows between the lens and the iris, drains through the trabecular meshwork into the canal of Schlemm. So the trabecular meshwork comes before. You can consider it as a sieve or a filtering tissue. When you have a mature cataract, this path is blocked, which would obviously means aqueous accumulating in the eye, which would mean rise in pressure. Phacomorphic glaucoma. Again, this use of glaucoma is antiquated. The other thing that could happen is this lens becomes or transfers into a Morgagnian cataract. Proteins leak, clog the trabecular meshwork, and result in a secondary open angle glaucoma or inflammatory glaucoma or phacolytic glaucoma, lytic from lysis of lens proteins. Or these proteins can simply leak into the anterior chamber, and since they were never processed, they incite a very strong autoimmune inflammatory reaction, which is called phacogenic uveitis. It was once called phacotoxic uveitis. Nobody uses that word anymore. So this is just a very small overview of how to deal with these complications of an unoperated cataract. Phacomorphic, control the IOP. We'll do that when we talk about angle closure, and then remove the cataract. Phacogenic, reduce the inflammation, remove the cataract. Secondary open angle, raise an IOP, control the IOP, remove the cataract. And if you have inflammation, obviously you control the inflammation as well. These are the terms that are now not in use. Phacogenic uveitis was called phacotoxic uveitis. I've already talked why it's not used. Secondary open angle is also called lens-induced inflammatory glaucoma, phacolytic glaucoma. Phacolytic glaucoma is also used. Lens-induced is used at times, but phacotoxic is not used anymore. So now that we have talked about the structure, the classification, the presentation, now we are moving on to the management part. And the most important part in the management part is to decide who gets to decide what to do with the cataract. The patient has a cataract. The patient can't do anything about the cataract. You can do something about the cataract, but you don't have the cataract. So you need to sort of balance the two and come to a mutual decision. And that mutual decision depends upon the disability that the patient presents with. And if the disability is enough that it causes or hampers activities of daily living, you proceed for surgery. And if it doesn't, don't. That's your ethical and moral obligation, that you tell the patient that at this point in time, the cataract is not hampering your vision, so let's not worry about it. And even if it's hampering your vision a little bit, your activities aren't affected. And that's really important, because unless the state pays for the surgery, the patient is going to be economically affected by time, etc. There are countries in the world, and there are procedures or protocols in the world that would say, oh, remove a cataract as soon as it develops because it's easier. Yes, it is easier, but it has a financial impact. Countries where the nation or the government funds healthcare, for example, Britain, they have a very good protocol, and people are usually wait for a very long time to get their chance at cataract surgery, get their chance of cataract surgery, because the state is paying for it, and you need to be very judicious in your use of your resources. So the general consensus is, if the patient's activities are affected, do surgery. Otherwise, you can scare the patient off. Oh, this cataract can develop overnight and you will become blind, and this cataract can explode in your eye and cause all sorts of problems, which is not really telling the truth. But the patient gets scared and said, yeah, fine, if I have to get surgery after 4 or 5 years, why not get it done now? But it's your ethical and moral job, ethical and moral responsibility to tell the patient the right thing and do the surgery if he is affected by it, i.e. his level of vision is something that's affecting what he wants to do. And the other thing that you really need to communicate really well is, what does cataract surgery have to offer? And many patients are under the impression that their vision would be exactly like it was when they were younger, which is not really correct, because removal of cataract would remove all issues that the cataract was causing, visual acuity, glare, but it will not, cataract surgery that is, will not improve any level of vision that was because of another problem altogether. For example, the patient had keratitis, which is inflammation of the cornea, which developed the cataract, but it also caused corneal scarring. Corneal scarring would impede vision depending upon where the scar is. You can't do anything about that when you're doing cataract surgery. If you are older and your retina has degenerated because of age, again, removing the cataract won't do anything. If you're diabetic, it won't do anything. If you've been taking steroids and it has caused glaucoma, it won't do anything. So you need to remember that cataract surgery only improves vision that is because of the presence of a cataract and not because of any other reason. This is very important that this is clearly communicated to your patients, because the patient can and at times expect that their vision would be just like when they were very, very young. Moving on, and before we talk about the actual management process, let's talk about eye status with regards to the lens in the eye when you do a torch examination. So the first one is a phakic eye. A phakic eye is one in which the person has his or her own lens, irrespective if it's clear or cataractous. If it's clear, it would have a grayish green color on torch examination. If it is cataractous, it would obviously produce some white change in color, but there would be some color. A pseudophakic eye is one in which the lens has been removed and an artificial lens has been implanted in the eye, and it produces a glassy reflection, a shiny reflection, because that artificial lens is made of a piece of plastic, and when light is shown across it, it produces a shine which can easily be seen. An aphakic eye is one in which the lens has been removed but nothing is implanted within the eye, so the pupil on torch examination appears jet black. And the reason, and I have put up this call out in black outline, is to show you that when you have no lens on torch examination, you really see nothing through the pupil. It's black. You can't see the arrowhead here because it's all black. You can see the arrowhead here. So the normal lens is not black in color. It is grayish green in color because it stands out against this black arrowhead. This is obviously shiny, as you can see the light shining off the lens. This is really important because this is a very important competence. It comes in OSCEs, and you should be able to detect it in your patients when you do a torch examination. Always. It's not that difficult. It just takes a bit of practice. Medicine mostly about practice. So now that we have talked about structure, classification, presentation, we are going to, and we've talked about management, it's basically surgery. We'll just talk about principles of surgery, have a look at some surgical techniques. The principles of surgery are, first of all, we do a relevant pre-op examination and we manage conditions that we find and investigate the patient. Then we identify a means of restoring the power after removal of lens. Remember, we are removing about 18 diopters. So we need to put that power back in the eye if the patient is going to see. And after all, that is our aim, to help the patient see again. Prep the patient for surgery, perform cataract surgery, and these are the procedures within it. Again, these are mostly to sort of make you aware of what goes on, so that you are sort of made aware of what goes on in the patient's head and the doctor's head as well. You need to mark the eye that needs to be operated and dilate the pupil. You will see why that is, because you need access in order to remove the cataractous lens and also to implant lens inside the eye, because that's the most common way of restoring power. We need to make sure that the patient vitals are stable and has been allowed to take all the medication he can, and we put an IV cannula because God forbid if you need to pass on any drugs in case of any allergic reactions, vein collapse really fast and you will never be able to find a cannula then. So put it before. Double check all investigations, especially the hepatitis profile, shift the patient to OT, prepare and give anesthesia, drape and perform surgery, check vitals, remove IV cannula, shift back to daycare or wherever the patient came from. So what is incomplete ocular examination? Basically, we're looking for any conditions that might affect the surgery or recovery after surgery. So we are looking for dry eyes. Dry eyes can cause discomfort after surgery and make the surgical procedure a little bit more painful for the patient. And we are also looking for conditions that might cause a dry eye, for example, blepharitis. We are looking for any sort of ocular, intraocular, or adnexal inflammations. All of these can complicate a surgery and can actually lead to infections in the eye if the inflammation was of infectious origin. Then we are looking for any conditions that might not or that might hamper full recovery of vision. For example, if there is pre-existing amblyopia, there was a congenital cataract that wasn't operated in time, or other causes of amblyopia. There are corneal scars which might indicate inflammations or trauma. Retinal diseases. At times it is possible that you can't look at the retina because the cataract is mature, and then what you do a B scan. A B scan is ultrasound of the eye. We have an entire video on B scan demonstration, so you can refer back to that video. But a B scan is only necessary when you can't get a view. You don't do a B scan in every patient. Then we do a relevant systemic evaluation. We are looking for diabetes and HbA1c of less than 7.5, BSR, BSF within normal limits. We are looking and controlling diabetes because it hampers wound healing. And if you do cataract surgery in a patient who has diabetes and the diabetic retinopathy if existing would accelerate, or if it hasn't or hasn't developed, would develop rather quicker. Hypertension needs to be controlled as per satisfaction of the primary care physician, simply because although the eye is an avascular structure, the retina is vascular, and when you enter the eye, you incise into the eye to remove the cataract, you suddenly lose the intraocular pressure. It's like a balloon in which you poke a little hole, not that dramatic. The effects of intraocular pressure on the retinal and choroidal vasculature reduces, and if those vessels are brittle or if the blood pressure within them is very high, they can bleed, and those types of bleeds are devastating. Hepatitis profile is really important for you more than the patients. You want to take extra precautions. For example, use double gloves, and instruments then need to be specific for those patients. Cardiac profile, ECG only for general anesthesia, and also for local anesthesia as well, as we'll see certain types of local anesthesia are also antiarrhythmic drugs. Xylocaine. So this is what our situation is in a normal eye. This is just to show you various chambers and segments and the power of the normal eye. The power of the normal eye was approximately 60, 42 coming from the cornea, 18 coming from the lens. The anterior chamber is the space between the cornea and the lens. The posterior chamber is occupied by the lens only. The anterior and posterior chamber together form the anterior segment. Everything behind the lens is the posterior segment. This is what we do when we do cataract surgery. We remove the lens, and we need to make up this power because we make the patient hypermetropic. Rather than 60, his eye is now only 42. And the ideal thing to do is to replace it with something that goes where the normal natural lens was. But it took quite a lot of time, and in fact, the first time a lens was placed where the normal lens was in the latter part of the last century, actually. Now it seems to be a long time, actually. Yeah, how this time flies. So how do we restore power? We need to make up this deficit, and we can do it either after surgery, which is the older way, or during surgery, which is the newer way. The after surgery bit is still used in children. So after surgery is either use contact lenses or aphakic spectacles, and this is right now today almost exclusively used in pediatric groups. Aphakic spectacles are a remnant of ICCE. ICCE is intracapsular cataract extraction. It was a type of surgery that was done once long time ago. I think 1950s or something thereabout it started off, or maybe even before that, and so it's not done anymore. So it's a remnant. The most modern way of doing is to implant something during surgery, which is called an intraocular lens. And now there are various types of intraocular lenses. We'll talk about them. And that's the most modern way of restoring power. So aphakic contacts and glasses are something that you use after surgery, and the power of the aphakic spectacles is about +10. And this is +10 considering they were emetropic prior to surgery. Obviously, this power would be more or less if they were not emetropic. There are two major issues with spectacles which makes them unsuitable as means of restoring vision after cataract surgery, and that is magnification and jack-in-the-box. We'll just see what those are in a bit. Contact lenses are preferred because they produce better vision, because the problems of magnification and jack-in-the-box are way reduced or non-existent. So what are the indications? Well, pediatric age group cataract surgery, as we have just said, because before 2 years of age, an intraocular lens is usually not implanted because the baby's eye is still increasing in size. So difficult to get an idea of what number of the intraocular lens to implant, as we'll just see how we determine that number. And remnant of intracapsular cataract extraction, ICCE, we've already talked about. This surgery is no longer done. So if you see individuals with aphakic glasses, they probably had surgery a long time ago. So this is a baby who is about to get a contact lens. You can see it on your face. This is the eye getting a contact lens. This is a baby with aphakic glasses. This is an elderly gentleman wearing aphakic glasses. So what is this jack-in-the-box phenomena and magnification? We'll just see them next. So this is magnification. It's very simple. It's a +10 lens. It's a converging lens, and converging lenses magnify. So what you do is when you wear this lens, everything appears closer, especially if you're climbing downstairs, they would appear closer to you and you are likely to fall and you misjudge distances. The other problem is called jack-in-the-box. And if you know what a jack-in-the-box is, it's a little toy that you wind up and you have usually a clown that pops out of it, which is called jack-in-the-box. And jack-in-the-box phenomena occurs because these glasses, aphakic glasses, do not have a +10 power everywhere. They have a +10 power in the center. Their peripheries are thinner and they don't have the same power as they do in the center. So maybe they have +5. So this is an individual's eye, and this individual is driving this car wearing aphakic glasses. And his own power is 42. With this +10 addition, light focuses on the retina. There's a car coming at an intersection, and at position A, the light rays don't even enter into the lens, the correcting lens or the spectacle, and so would have a hypermetropic focus simply because they're only getting 42 diopters of power. Remember, you need 60 diopters to get onto the lens. So this is a jack-in-the-box. You can't see the car. It's right there. You can't see it because it's not properly focused. So the car moves a little closer to you, go to point B, and now you have light rays that strike the lens, but through the part which is thinner, and still you don't get a clear focus. So you still have a very blurry view of the car. You don't have a clear view that you have a car here. Our jack-in-the-box is still closed. Now the car gets to position C, and it's only when it's right about to overtake that you get a clear picture or a clear view of the car, and the car suddenly pops up in your visual field. You couldn't see it properly at A or B. It's only at C, when it's right there staring at you, do you see it, and this is where your jack-in-the-box pop opens. So the things suddenly appear in your visual field. If you were a normal individual and light rays, irrespective at A, B, or C, would reach your eye because you would have a lens here, and you would get the entire 60 diopters of power irrespective if the light was coming from A or B, because the eye power that the light rays would be exposed to would be full. It's only because of this spectacle is a problem. Even if I was wearing a contact lens right here, this problem wouldn't exist because the contact lens is right over the cornea, so you won't have jack-in-the-box issues. So as you can see, if the patient is wearing a contact lens instead of the +10 aphakic spectacle, all of the light rays, irrespective if they are at A, B, or C, they would all tend to focus onto the retina. And the reason that's happening is because the contact lens conforms to the shape of the cornea. So whatever light has to pass through cornea passes through the contact lens first. So irrespective if the car is at A, B, or C, all of these light rays are going to pass through to the contact lens, through to the eyeball, thus appropriately focus onto the retina. Thus, you won't have this jack-in-the-box phenomena with a contact lens. You will still have a little bit of an issue with magnification, but not jack-in-the-box. Obviously, these light rays appear to you to be bending from the wrong point because I just put a contact lens in, but assume that these light rays are bending at the point the contact lens starts. The most common way of restoring power is implanting an intraocular lens during surgery, or an IOL. There are of various types, and that is dependent upon where they're implanted, which can make them anterior chamber or posterior chamber lenses, or the type of material that these lenses are made of, rigid or foldable. So the position of the eye would be a posterior chamber IOL or an anterior chamber IOL. IOL material would be rigid or foldable. Foldables are the most common type of lenses used, and all of them are of the posterior chamber type. So let's look at an anterior chamber IOL. This is how an anterior chamber IOL looks like. An IOL, remember, is supposed to focus light, so it has to have a part that focuses light, which is called the optic. It also needs to be supported within the eye, which is done by the help of the feet, which are called the haptic. These are the type of lenses that you implant in the eye if you have no support to put a lens where the normal lens was. See, if I put this lens here, it'll just fall in the vitreous cavity because there is no support. How do we get the support or maintain that support? We'll just see. But these are the type of lenses that you implant when then you have no support of putting a lens in the posterior chamber, and that support comes in the form of the posterior capsule of the lens. So modern cataract surgery is done in a way so that the posterior capsule of the lens remains in place, so we can put a lens there. So this is something that is only used if you lose this support. Obviously, you can do modern surgery and have a complication in which the support is used. So these lenses are still used, but they're not the most common way of doing this. They're these days used mostly as a consequence of complication of routine cataract surgery. They provide good vision. They're within the eye, but they're not at a location where the normal lens is. And because they are basically going to cover the pupillary area, which is a pathway for the aqueous to enter the anterior chamber and exit the eye through the trabecular meshwork, you create a little opening in the iris called a peripheral iridotomy. We'll talk more about iridotomies when we talk about angle closure, but I'll just show you a picture that this is what happens, that the lens can potentially block the flow of aqueous. So you create an alternate pathway so that the aqueous flow is still maintained. It's called a peripheral iridotomy. It is usually made, this iridotomy, using lasers. This is the peripheral iridotomy. This is the anterior chamber IOL, and you can see it is the optic part. This part covers the pupil and can block the flow of aqueous. This is a posterior chamber IOL. These are the most common type of lenses implanted. And this is, again, it's optic. These are the haptics. Haptic at the feet, optic is the area through which the light focuses. And as you can see, we have left the posterior capsule of the lens behind because this now is providing support for this lens so that it doesn't fall into the vitreous, and provides the best visual recovery because this lens is where the normal lens was. And as you can see, it does nothing to the flow of the aqueous, so you don't need a peripheral iridotomy. This is how a posterior chamber IOL would appear to you. And this is a rigid posterior chamber IOL, by the way. What is rigid, what is foldable is just coming up. It has these dialing holes, so you can adjust the position within the eye. Haptic, optic. So the other way of classifying lenses was rigid or foldable. Rigid IOLs are made up of a plastic called PMMA, polymethyl methacrylate. All AC IOL designs, anterior chamber lens designs, almost all of them are of the rigid variety. Older design posterior chamber IOLs, which are still in use, you can do modern day cataract surgery and still implant these lenses because they're cheaper. But older design posterior chamber lenses are of rigid material. The modern intraocular lens is a foldable lens, and they are implanted after phacoemulsification surgery. What is the advantage of folding them? Why were they invented? It will become clear once we talk about phacoemulsification. They're most of the time made of acrylic. Silicone was once used, it's not used anymore. And foldable IOLs, the ones that you implant these days, can be multifocal as well. So they can provide near and distant visual acuity. Remember, once you do cataract surgery and implant a lens, that lens usually is unifocal, fixes for one distance. But there are lenses that can fix you for multiple distances. There are lenses that can correct pre-existing astigmatism as well if you implant a toric IOL. And now you have modern lenses that can also accommodate a little bit. So they can provide variable distances, clear focal. So rather than multifocal fixed distance clear image for distance, intermediate, and near, these IOLs can provide a variable viewing range to the patient. They're not that common. especially in our part of the world, because they tend to be pretty expensive. But multifocal and toric can and are used in Pakistan as well. But again, just as with multifocal lenses, you need to have a little bit of practice to get used to them. Toric are useful if you have high levels of astigmatism and you would not like to wear glasses after cataract surgery. So how do we actually determine what would be the power of this lens that goes into your eye? Remember, not all eyes would have a same amount of power. We have done that when we did refractive errors. We say the power is 60, but then we say the axial length has to be 22.6 millimeters in order for the 60 diopters to focus light on the retina. Not every eye is going to be 22.6. So the cornea and the axial length and the lens would have an interplay between them. Hey, I'm a little shorter, you have a little bit more power, so the light still focuses on the retina. So we need to determine exactly what power to put in the eye. It can be greater or less than 18 because not all eyes are similar, as we talked about. We also talked about it when we did refractive errors. So we need to determine the power of the lens to put in, and we know that there are three determinants that basically decide where the image will be formed in the eye, which is the axial length, the power of cornea, and the power of lens. To calculate the power of intraocular lens, we do a process called biometry. And in this biometry, what we are trying to determine is, if we take this out, what will be the power of the lens if we can measure the length of the eyeball and power of the cornea. Remember, not all corneas would be 42 because of the reasons we just described before. And length obviously can vary. So we can use these two variables, power of cornea and length of eyeball. And again, the length of eyeball is 22 to 24 normal. You can have a patient who is myopic or hypermetropic and wants cataract surgery. So all of these variables need to be calculated, length of eyeball and power of cornea. And we put all of these values once calculated into a formula. There are many formula, of which the oldest is SRK. I'm just reproducing SRK here because it's one of the simplest ones to put on paper. And it is A minus 2.9 multiplied by length of eyeball plus 0.9 multiplied by K. K is the power of the cornea. We'll see how these measurements are done. Length is measured using ultrasound or optical way, which is lasers. Lasers is newer, but ultrasound is still common. It's called an A scan. And as you can see, if I make an error of 1 millimeter in measurement, length of eyeball is measured in millimeters, that error is magnified 3 times. Power of cornea is measured using a keratometry. It is measured using automated keratometer, which is very similar to an automated refractor. I'll show you how it's done in a video in just a bit. But getting K wrong is not as bad as getting axial length wrong because it's not magnified. In fact, the value is slightly reduced. So this is how the display or the peaks of A scan ultrasound appears. Ultrasound, remember, is based upon various acoustic densities of the medium through which the sound travels. So when just like refractive index for light, you have acoustic index. I don't think it's called acoustic index, but something similar. So it reflects light back when the medium changes, and every time the reflects sound back, sorry. So every time the sound is reflected back, it is picked up by the machine and produces these peaks. I'll show you how it's done. And we already talked about corneal power when we talked about refractive errors. We talked about corneal meridian. So we measured the power in the X and Y meridian, the two principal meridians, and we'll see how that is done in a bit. Let's see a video of how biometry is done. So now we are doing some calculations for biometry, or calculation for the power of the intraocular lens that needs to be implanted in the eye. And we are using the same machine that we did when we were trying to find out the refractive status of a patient. This time the machine is put into a different mode to measure the corneal curvatures. And the patient is positioned just as before. Assalamu alaikum, मेरा नाम डॉक्टर अली है. आज मैं आपकी आँख का मुआयना करूँगा. तो आपकी आँख का ऑपरेशन होना है जिसमें आपको आँख के अंदर आना डालना है. उसका नंबर निकालने के लिए ज़रूरी है कि आँख का कुछ हिसाब लिया जाए. ठीक है, आप अपनी थोड़ी वहीं पर रखें, नीचे इधर, सर ऊपर साथ लगा लें. And just as before, we focus one eye. And when the machine has taken its reading, it will say finished. And if you are doing the right eye, we do it for the right eye. If you are doing surgery for left eye, or if you are planning surgery for both eyes, stepwise, we can do both eyes, and we can take a printout again. this is a printout, and we have discussed this printout when we were doing the discussion on cataract. So once we are done with the calculation of the corneal curvatures, we are now going to measure the axial length of the eyeball. The corneal curvatures were done using the autorefractor keratometer, the same machine that is used to find out the refractive errors, if any, a patient has, or a refractive status of a patient also is used to measure the corneal curvatures, and we did that before, and now we are going to measure the axial length and also put the formula in the machine, the values in the machine, so that it can calculate the numbers, the number of the intraocular lens that needs to be implanted. Assalamu alaikum. जो हमने काम पहले शुरू किया था, आपकी आंख के अंदर जो शीशा डालेंगे उसके नंबर को निकालने के लिए, अब उसके अगले मरहले में पहुंचेंगे. इसमें हम करेंगे क्या कि ये कतरा आपकी आंख में डालेंगे, ये कतरा आपकी आंख को सुन कर देगा. ये टिश्यू पेपर में आपको पकड़ाऊंगा, इससे आप अपनी आंख को खुश कर सकती हैं, साफ कर सकती हैं. इस तरह का ये एक मशीन का हिस्सा है जो आपकी आंख को आके लगेगा, क्योंकि आपकी आंख सुन हुई भी होगी, आपको महसूस नहीं होगा कि ये आपकी आंख को लग रहे हैं. टेस्ट के दौरान आपने बिल्कुल सीधा देखते रहना है. कोशिश करिए कि आंख ना हिलाएं और आंख झपके भी नहीं, क्योंकि उससे इस टेस्ट में जो ये टेस्ट होता है उसमें थोड़ी सी रद्दोबदल हो सकती है, जिससे हो सकता है शीशे के नंबर ठीक ना आए. ठीक है, आपकी इजाजत है? ठीक है. सो आई एम गोइंग टू बिगिन बाय पुटिंग अ ड्रॉप ऑफ एनेस्थेटिक इन द पेशेंट्स आई, एंड देन वी विल प्रोसीड ऑन विद आवर टेस्ट. आप ऊपर छत को देखिएगा, मैं आपकी आंख को थोड़ा सा हाथ लगाऊंगा, आपको दर्द या तकलीफ नहीं होगी. So the way we put a drop in is to make sure you have the cap off, and the bottle should not touch the patient's eye. So what you do is, ऊपर देखते हैं, use your finger, or horizontal finger is very good. Pull the lower lid down gently. Make sure your nails are clipped, your hands are warm. And as you pull the lid down, you'll create a little conjunctival sac. Put the bottle vertically and drop a drop inside the eye. आंखें साफ कर लें. The anesthetic will take about 15 to 20 seconds to work. थोड़ी सी चुभन होगी, फिर उसके बाद आपकी आंख सुन जाएगी. Then we take our probe, and if you can see the probe has a little light. This light does not do actual measurement. This is just a targeting light, or a light that we can use to know where our probe is going, and we usually clean it before we actually start using it. So this is the probe, and it's cleaned already, and the machine is primed and prepped to do it, and I'll tell you how the machine displays things once we are done with the test. So this is going to touch the cornea, this end of the probe, and we don't press too hard, just gently, so that we can start the measurement of the axial length, which is between the cornea and the retina. सीधा देखते रहिएगा, सीधा देखिएगा. मैं आपकी आंख को थोड़ा सा खोल दूंगा, सीधा देखती रहें. Alright, once the test is done, you'll hear different beeps, and when the final beep is a longer beep, so you know that your test is done. Aapka bahut bahut shukriya. And now what we'll do, we'll just look at the screen. This is the same picture that we saw when we were doing our discussion on cataract and cataract management. And you can see various peaks that are visible on the display. And remember, the peaks are, this is the peak that is coming from your cornea, this is the peak coming from the anterior lens capsule, this is from the posterior lens capsule, all of this is the vitreous, and this is the retina, and behind the retina, optic nerve, orbital tissue, sclera are these signals. And these are just reflections based on acoustic densities of the various mediums. And what we are trying to do is to calculate the distance between the cornea and the retina, and the machine has done it, and all the displays are here. Now, I'm sure you're not able to see it very clearly. If you are, that's very good. But what we are trying to show is that the machine takes multiple readings. That's really essential, because you can't just take one reading, you take many readings, and what you do, you take an average of those readings, which is this bold right here, and the below the bold, sorry, right here, which says average is 22.73, and remember the mean length of the eyeball is between 22 and 24 millimeters. What tells you that you have done a really good job or not is the standard deviation. The standard deviation basically tells you how much of a difference exists in between all the readings you took. And generally, any values below 0.2 is considered to be very good. Ours is 0.03, so which is even better than very good. So the reason it takes multiple readings is just to get a mean reading. So because your hand is might move a little bit. If it's touching the cornea, might touch a little more, little less when the reading is take place. So many readings to take a mean out to have a greater level of accuracy. Now we are going to calculate the exact power of the lens, and remember we need one more reading, and that reading comes from the other machine that we use, the auto refraction bit, which is this printout right here. And since we did the right eye, we are going to enter the values of the right eye. We're going to press the biometry button, and this is going to bring us to a new screen. And as you can see, we already have the axial length, and what we need are the corneal curvatures, which is R1 and R2. So we are going to just press the button here, and we're going to edit our value. The value of our R1 and R2 are corneal diameters in the vertical and horizontal meridians. So we are going to enter them right here. It is 44.5. Remember, the cornea generates a power of about 42. So this cornea in one meridian is slightly higher, but we need to take a mean. The other R in the other dimension is 44.75. So this cornea is slightly above in its curvature of what a normal cornea usually is. Now we got these two readings. We just need to put one more, the A reading, or the A constant, which varies by the lens. And our A constant that we use in our lens is 118, and we enter that here. And the machine then gives us what lenses to implant in the eye. And I'm going to just sort of lower it and show you that for this patient we need to put in a lens of 21 diopters, and that would result in no refractive error, meaning that once we put this lens in, and considering that the cornea and the retina and the other bits of eye are okay, this should get us a normal vision post-cataract surgery. If the cataract surgery is uneventful, there is not much, we are doing phacoemulsification, the chances of post-op astigmatism are to an extent nullified. We can also increase the number to induce a refractive error, and this is sometimes important. For example, if your patient says he wants to be able to read without glasses, because remember, once you do surgery, most of the lenses, almost all of the lenses, maybe 99% of lenses implanted, are not accommodating. So you can just adjust a little bit of number. That might make distant vision difficult, but since most of these patients are elderly and they're more interested in reading, they would benefit if they can read without glasses. So that is how biometry is done. I hope you have enough of an understanding so that if some of your patients ask you what biometry is, you would be able to, tell them confidently. So moving on, we have reached a stage where we have determined what to put in the eye, the power of the intraocular lens. Now we need to prep the patient and perform surgery, and the most important thing here is to mark the right eye. It is very easy to operate on the wrong eye, especially if you have a very busy OT. So you mark the eye, you take a skin marker, put an X, or you put a little bit of sticky tape, which can be used on the skin, and you put an X on it. The eye that's to be operated. You wouldn't imagine the amount of times the wrong eye has been operated on. Since most of the cataracts are bilateral, that's not the most problematic thing in the world. Imagine taking the wrong kidney out. Then you need to dilate the pupil for good access to the anterior capsule, which we need to remove in order to actually take the cataract out of the eye. We use tropicamide eye drop, which is a parasympathol lytic agent. One drop every 15 minutes. We need about a pupillary size of 10 to 12 diameters. We again check our essential vitals, and we may ensure that the patient has taken allowed medication. The only medication that we really worry about is anticoagulants, which may be stopped if the relevant physician says yes, you need to stop them. Double check all the investigations, shift the patient to OT. There are various types of anesthesia. The most common type of anesthesia is local anesthesia, which provides both anesthesia and akinesia. Analgesia and akinesia. The eye can move even if it's not receptive to pain, i.e. you need analgesia as well as akinesia. So that means that your eye doesn't move and doesn't feel pain. You can do general or something called MAC. MAC is local anesthesia plus sedation and analgesia. General anesthesia is for children, special cases, or people who just prefer general anesthesia. These days, surgery can be done under topical anesthesia, just proparacaine eye drops, the same drop we use to do biometry. You need a very cooperative patient because you're only getting analgesia and no akinesia. As I said, local anesthesia is the most common. Lignocaine and bupivacaine, short-acting plus long-acting agents together, which is injected either behind the eye or around the eyeball. We don't do around behind the eyeball, the retrobulbar type anymore. But I'll show you pictures of both. Dre perform surgery, check vitals, remove cannula, shift back once you are done with the procedure. So this is a local anesthesia peribulbar block around the eyeball. So it's again xylocaine plus bupivacaine around the eyeball. We use this because we don't really need to inject a lot of material, and surgical times have sort of become much less as compared to the time when this was used, retrobulbar. Retrobulbar anesthesia means going behind the eyeball and injecting your anesthetic agent. This is dangerous because once you're behind the globe, you're blind. You can hit a blood vessel, which is really dangerous because it can cause a huge hemorrhage and has its own problems that we'll do when we talk about complications of cataract surgery. This is a timeline of cataract and cataract surgery, and we have known about cataract for more than 6,000 years now. This is a statue or a bust of an Egyptian priest, which shows a difference in color between the two eyes. As you can notice, the left eye is white, which indicates to us that people at that time knew that there is something wrong with the eye. So they knew they had an idea about cataract. It wasn't obviously called cataract at that time. 4,500 years ago, we have first evidence of cataract surgery called couching. Unfortunately, it's still being performed today. It's called couching because the person doing the surgery was called a coucher. 1000 AD, we have a very unique or an interesting procedure called lens suction, in which a hollow tube was used to suck the lens out of the eye by a person who has a lot of lung capacity. 1800, we have Samuel Shaw performing the first intracapsular cataract extraction, or ICCE. In 1950, we have Harold Ridley performing the first extracapsular cataract extraction with an intraocular lens implant. And in 1967, we have the first phacoemulsification. This is a summary of what we just talked about. Couching should not be done. It's unethical, it's criminal, but it's still being done. Intracapsular cataract extraction can be considered obsolete. Extracapsular cataract extraction is becoming obsolete. Phacoemulsification is the procedure of choice, in which we use ultrasound waves to break the nucleus within the eye so that it can be removed through a small corneal incision. And as you'll see, why is a small corneal incision beneficial when we see the videos, which is just coming up. This is almost always done with a lens, and as we have seen, this is a foldable lens, and that could be unifocal, which could work for near or distance. Remember, we can adjust the value in biometry if the patient desires to have clear near vision. It can be multifocal as well, work for multiple distances. It can be self-accommodating, variable distances, and on toric. But by far the most common type of lens implanted is a unifocal lens. This is couching. Couching was basically called couching because the patient used to sit on a couch, and the coucher was sitting literally on top of the patient. And you use a needle called a couching needle to break the zonules and push the cataractus lens back into the vitreous. So this was first described in Kota Hammurabi and written down, but the procedure was popularized by Maharishi Sushruta in 800 BC. And the visual restoration was leaving the patient aphakic. Remember, the patient with the cataract is perhaps light positive, the cataract is so dense, and remember, it's a last resort thing, and removing the cataract would at least give him counting fingers vision, even with just 42 diopters of power left. Once spectacles were invented, you could give spectacles. I'm not sure what came first, spectacles or cataract surgery. So if they came after, it was after. If it was before, if like spectacles were known before, then probably after couching was done, aphakic spectacles were provided, but I'm not sure about that. So this is couching. This is called a couching needle. So it's introduced through the limbus or slightly away from it to break the zonules. Once you break the zonules, you throw the lens back into the vitreous. You would say, hey, doc, you said this lens would react. It's foreign. Yes, I did, but it's still surrounded by the capsule. Nothing has leaked out. Would not cause any problems lying there. And the visual axis is now clear. You'll get counting finger vision, which is better than light perception that was with the mature cataract. And remember, this was a time when surgery was done as a last resort, when the patient was literally just seeing light and nothing else. I'll show you a small video of couching. Yes, something that was done 2500 BC. We have a video for that. This video will demonstrate couching, and before I start the video, I've been told that my understanding of couching is a little misplaced. It's not because the patient is sitting on a couch, it's because the process is called couching, and the person performing this procedure is called a coucher. So let's see this video. And this is the patient, and he is sitting on sort of a couch, and this is the coucher or the doctor, and he is cleaning the eye. He is also going to use a makeshift way of sterilizing, cleaning his hands, and that's a towel to clean his hands and I guess his face. He's also going to put a mask on. That's the mask. Everybody is wearing a mask these days, so I guess it's a pretty common sight nowadays. So this is the couching needle, and the eye has been anesthetized, and it is going to be introduced from the limbus to the patient's right eye. He's using his thumb because remember it's an analgized eye, there is no akinesia. It's introduced through the limbus to break the zonules, and right now it's all a blind process. He's just from his experience twisting his needle to break the zonules and moving it up and down. He's blind and we are blind because the eye is pretty much closed right now, the patient's eye. Now the eye is held open and he is going to sweep his needle so as to displace the lens into the vitreous, as we saw in our presentation before. And you will see the couching needle move, here we go, come into the pupillary axis, into vision here multiple times. There we go, that's the needle coming in. So that means that the nucleus, here we go, it's very clearly visible now, the couching needle in the pupillary area. So that means the nucleus has now been displaced into the vitreous. Clean away a few tears. And he's just going to do a little bit of counting finger visions because that's the best you would expect without glasses. And exchange of money. And that is what couching is. Shouldn't be done, and as you see this video, this is I think from 98 or thereabouts, it's still being performed. So the next procedure in chronological order that we are discussing is called intracapsular cataract extraction. And rather than throwing the lens back into the vitreous as what with couching, we are now producing an incision in the cornea which is large enough to remove the entire lens, lock, stock, and barrel, out of the eye. And this was done using something called a cryoprobe. A cryo means cold. So you touch this probe on the lens, you press a pedal, it uses liquid nitrogen, and it freezes to the lens using cold, freezes to the lens using cold. Freeze. It fuses with the lens with cold. It reduces the temperature at the probe to minus something degrees, and it fuses to the lens and you pull it out. And this procedure was done at a time where you could provide spectacles. And once anterior chamber IOLs were available, you can put an anterior chamber IOL in front of the iris because there is no space here, but there is space in front of the iris. So this is intracapsular cataract extraction. All of the lens is gone. We removed it out of the eye, didn't throw it into the vitreous. So we either give them aphakic spectacles or anterior chamber IOLs. Now what would follow is a small video demonstrating intracapsular cataract extraction. This video demonstrates intracapsular cataract extraction, a procedure that's very rarely, extremely rarely performed these days, but it's still good to know how it's done because this was the first modern surgical procedure to remove cataract from the eye. So we are going to start. This is the cryoprobe. This is a sponge, and you'll see why it's required. Because as the lens is delivered from the eye, the cryoprobe fuses with the lens through cold. A lot of vitreous will come out because behind the lens is the vitreous, and it will prolapse because there is no support. So the sponge is here to soak the vitreous, and I'm just going to pause the video here slightly to show you certain landmarks. Just take it. Yeah, here we go. So this is the cryoprobe, and once you turn it on, it turns a little bit. It turns a little white simply because it becomes cold. So all the moisture freezes, and it is through this cold that it creates a bond with the lens, and the lens is soaked in aqueous. So when it touches the lens, the aqueous freezes and it sort of fuses to the cryoprobe. The lens capsule fuses to the cryoprobe. This sponge is there to soak all the vitreous. Behind the lens is the vitreous. It's going to come out as soon as the lens is delivered because there is really nothing holding it back. And this is the large corneal incision. The cornea is being held by a forceps through which the entire lens is delivered. Remember, we are delivering the entire lens in this case, leaving the patient aphakic with no possibility of putting a posterior chamber IOL normally. So an anterior chamber IOL would be placed in this eye. So let's move this forward in time. The lens is being delivered, the entire lens, and here we go. A large blob of vitreous comes out. The vitreous is going to be cut. And remember, we can't leave vitreous in the anterior chamber because it can block the angle, cause glaucoma and also inflammation. So we constrict the pupil because that is where the lens would rest. We insert a glass slide, and this is an anterior chamber IOL. You can see from its shape being inserted into the anterior chamber in front of the iris. The iris needed to be constricted, or the pupil needed to be constricted so that the lens has some support. And you can see some sutures were applied to make the wound a little smaller so that the lens can stay inside the eye. So large wound requiring a lot of sutures to close. And finally, this is a fluorescent dye. This is a dye that's used in many places, as you'll see as you move on in the clerkship. Right now, it's being used to see if the wound is sealed or not. So this is how intracapsular cataract extraction was done. Now we're getting towards the slightly modern approach or moderner approach, and this is called extracapsular cataract extraction. And this was the first type of surgery that was done in which some support was left so that a lens can be implanted in the posterior chamber area, a posterior chamber IOL. So it's called extracapsular cataract extraction because it is extra to the capsule. You're leaving a part of the capsule behind. So what you do is you again give your corneal incision, but rather than removing the lens as a whole, you just remove the anterior bit of the lens capsule, which is called capsulotomy. And once the anterior bit of the lens capsule is exposed, right underneath is the cortex, and below the cortex is the nucleus, sandwiched in between the cortex. And then you can express the nucleus out, like shown here. Wash the cortex. Insert a posterior chamber IOL, shown here. Here the arrow is showing one of the haptics. The other haptic is in the eye, and this is the optic. Difficult to pick up, but this light is shining off the optic. It will be implanted behind the iris in the posterior chamber space, and you close the wound with sutures. You also close the wound of the intracapsular cataract extraction with sutures, as you've seen in the video, but these are the sutures. I have deliberately put the sutures here for a reason. So this is what intracapsular cataract extraction is. You remove the anterior capsule, you take the nucleus out, wash the cortex, leaving the posterior capsule behind, and you can now implant a posterior chamber IOL. Best results. Now what will follow is a small video demonstrating extracapsular cataract extraction. Let's see a video of extracapsular cataract extraction, surgery that was popular until phacoemulsification came along. So this is a protective gel that's used because of all the instruments that are going to get in. We need to protect the corneal endothelium, and this is that cystotome. And see how a zigzag-like capsulotomy is being created, and compare it to the capsulotomy of the phacoemulsification that's going to come. We're going to talk about this a little bit later, but see how it's just a rough cutting of the anterior capsule of the lens. We need to cut the anterior capsule because this time we're not delivering the entire lens. We're just going to take the nucleus out, wash the cortex, so we still have the posterior capsule. So this is the anterior capsule, and it's being cut off the lens, or you can say it's been excised off the lens, and it will be pulled out with a forceps. And below this, you see the cortex and the nucleus. So this is just enlarging the wound. He didn't pull it out with the forceps, so he's just going to deliver it when the nucleus comes out. He's enlarging the wound because the large nucleus needs to come out of the lens. Remember, we are not delivering the entire lens now. We are leaving the posterior capsule behind. Nucleus is out. You see a little bit of cortical material, that white fibrillary material light here, all of this. It's going to be washed out. See the iris prolapsing? It's going to be pushed back in by an instrument, iris repositor. So this material is being washed. You now can't leave the cortex in because this is foreign to the body. It was always trapped within the lens, so it will incite a very strong inflammatory reaction. So it needs to be carefully washed out. Some more of that protective gel before putting in the intraocular lens. Is this time a posterior chamber intraocular lens can be put in because we left the posterior capsule intact. So this lens will go behind the iris over the posterior capsule. This is the posterior chamber lens. You can see how it looks differently. We have seen a shape. So it's just going to be pushed behind the iris over the posterior capsule. We have taken the nucleus out, as you see, washed the cortex away. The iris is pushed back in again. Just some final adjustments, and now the wound is going to be closed. And again, large wound, not as large as intracapsular because we were delivering the entire lens then. We are just delivering the nucleus, so relatively smaller but still large, requiring sutures which can induce astigmatism. This is a 10-0 nylon monofilament suture. It's a very thin suture, very, very difficult to see if you're not seeing it under a microscope. And most of the surgical time in an extracapsular and even intracapsular cataract extraction was for putting in sutures. I mean, anything between 50 to 60% of total surgical time is applying sutures. So once all the sutures are applied, the surgery is basically complete. So this is extracapsular cataract extraction. And you can see the shiny reflex of the intraocular lens. This is just to test if the wound is sealed, and that's it. Thank you for watching ECCE. Finally, we are coming to what we do these days, what everybody wants to learn when you're doing your eye training. It's like, you know, how to cook a round chapati. Or is that being too feminist? You know, males can cook chapatis. What else can I say? It's like learning how to drive a car. In fact, that's even better. If you can drive a stick shift, you can do phacoemulsification. Because it's just foot and hand control. And that's about it. So if you are good at stick shift, by stick shift, I mean a manual car, not an automatic car. Because an automatic car is not something that's really, you know, you don't learn to drive an automatic. An automatic basically drives for you. I know that's not the best thing to say, but it's so much more easier to drive an automatic rather than a stick shift. Those of you who have driven both would know it's not much fun to drive an automatic, but a stick shift is, you know, it's like you're a noob, you drive an automatic. You're a pro, you drive a stick shift. I drive an automatic. But all my life, apart from the last 7 years, I used to drive a stick shift. I was always told automatics are unreliable. I am not sure if they are unreliable, but time will tell. Anyways, phacoemulsification. What is phacoemulsification? Well, phacoemulsification, the entire reason for evolving, or Dr. Kleinman, who actually invented this, his reasoning was, and it's given right here, is when you do extracapsular cataract extraction, you're doing a great job. You're putting a lens where it's supposed to go. Your eye is fine, but when you put sutures, And remember, look at these sutures, and I deliberately put sutures like these. Some of them are loose, some of them are tight. So the cornea is being unequally pulled, resulting in postoperative astigmatism. So you've done everything right, but the patient is going to need glasses or spectacles for distant vision and even for near vision, because obviously these are not going to accommodate. And obviously these are patients who are at an age where they become presbyopic. Remember, most cataracts are senile, primary cataracts. Even secondary cataracts are usually beyond the age of 40, mostly, not always. But the most common type of a cataract is in an individual who is of a presbyopic age. So you have sutures which are unequally applied, and even irrespective of how good a surgeon you are, there is some level of difference in application of sutures because humans are doing it. So perfect surgery, astigmatism, glasses. So he thought, he was sitting in a dental clinic and he was here for a tooth extraction, and his dentist used ultrasound to break a tooth. And that got him thinking, and he thought, if you can break a tooth with an ultrasound, why can't you break a nucleus? He was an ophthalmologist, by the way. So he developed this machine, took 5 hours to complete the surgery. I think it was 5, maybe it was longer. So what you do in phacoemulsification, you have an entire machine that generates sound waves, and those sound waves come through the eye to something called a phacoemulsification probe. And this is the tip of the probe that's seen here. This tip is very clever. Not only does it provide ultrasound waves coming in, it also has a vacuum, and it also has aspiration flow lines. So it is providing liquid into the anterior chamber of the eye. It is also providing ultrasound waves, and it is also providing vacuum. So what it does is, you do your capsulotomy, which is now called capsulorhexis. You open up your anterior capsule, and then you have the cortex and the nucleus right there. So you introduce this phacoemulsification probe, and it generates ultrasound waves, and those vibrations break the nucleus down, just like you can break kidney stones down with sound waves, lithotripsy. But Kleinman's inspiration wasn't lithotripsy, it was a tooth. I hope I've got my story straight. So this tip or this probe is called the phacoemulsifier probe, and the entire advantage of this surgery is the entire incision size is about the width of this tip that's going into the eye. Remember, for extracapsular cataract extraction, if you may permit me to go back, your wound has to be large enough to permit this nucleus to come out of the eye, and this is a large wound requiring 6 sutures. This wound does not require any sutures. We'll see in the video how it is sealed. So if your wound is small, you don't need a large lens. So together with the development of phacoemulsification, little after that, not immediately at this time, came foldable IOLs that could be inserted through that small incision. But that was ages ago. Now foldable IOLs are everywhere. When India started making them, the cost went way down. Indian foldable IOLs are about 2,000 rupees, even cheaper, I think. And they do work good enough. 6/6 vision good enough. So the entire benefit of this procedure is no sutures. That's it. We did phacoemulsification because no sutures. Such a big deal because now you have no astigmatism. You don't need glasses. This video demonstrates phacoemulsification, and this is a stabilizing ring that is used to stabilize the eye. This surgery is done under topical anesthesia, so no akinesia. And this is called a keratome. This silver thing, this is a specialized knife of a fixed size, and this area where the cornea is being excised, the surgical site, it is also called the surgical wound. This is going to remain of this size. You saw the surgical excision of the cornea of the surgical wound in intracap and extracap, and its extensive size as compared to this requiring multiple sutures. The entire surgery and the insertion of lens is going to take place through just this area, and thus the beauty of the surgery that it doesn't require any sutures at the end. So he's going to use this instrument to create his capsulotomy, which is now called capsulorhexis. And if you see the difference between this and how this was done in extracapsular cataract extraction, where it was called capsulotomy, when phaco was sort of popularized, this procedure was called capsulorhexis. It's still a type of capsulotomy. We'll talk about this in a bit. And rather than just roughly creating a zigzag or a rough edges as we did in extracapsular cataract extraction and phacoemulsification, a very smooth capsulotomy called capsulorhexis is done. The reason for this is because when a phaco probe is inserted, it applies pressure to the capsule, and that pressure needs to be evenly distributed. If it's not, it might produce a tear that might extend to the posterior capsule. That will be better understood when we talk about capsulotomies as just coming after these videos. But you see how this is a very smooth and a continuous removal of the interior capsule, and it's very calculated. In fact, this is one of the most important and crucial steps in phacoemulsification. Good capsulotomy, capsulorhexis, which is now called capsulorhexis, means that your procedure would be very easy to do. This is just to separate the capsule from the underlying nucleus, and as the capsulotomy or the excised part of the capsule is removed, this is the nucleus and the cortex. So this is again that protective gel that's inserted to protect the corneal endothelium. And this is our phacoemulsification probe, and the tip goes into the eye. Remember, it irrigates, it provides ultrasound, and also provides vacuum to suck things out. This is a second instrument to aid in the procedure. And as you can see, as phaco power is applied, the nucleus is broken down and is sucked out through the vacuum. And to refill the chamber as things are being sucked out, it provides fluid as well through the same tip. And as you can see, as the nucleus is chipped away and sucked out, you are again able to see a very clear red reflex because the nucleus is taken out. So rather than delivering the nucleus as a whole through a large wound, the nucleus is emulsified within the eye, delivered out through a small wound. See how quick that was? And now we are left with the cortical material, and the cortex needs to be washed out. Here we go. This is another instrument to wash out the cortex. And once the cortex has been mostly cleared away, a little bit of protective gel again before putting in the lens. And as you'll see, this is a lens that put in through an injector. An injector is an instrument that can be used to put a foldable lens in the eye, and this is the injector going in. Here we go. The injector goes inside the eye. This is the injector, and it's pushing the intraocular lens out, and the lens is folded, and you'll see it slowly opens within the eye. So this is another instrument that's being used to nudge the lens to open up, and the lens is now open. And as you saw, the entire surgery is done through that really small incision. So whatever little bit of cortex was left is going to be washed out, and no stitches are applied. What we're going to use is a little bit of fluid to hydrate our wound right here. You can see creating a little bit of corneal edema, little bit here and here, just to seal the wound. No sutures required, surgery complete, minimal astigmatism. This surgery took about 4 minutes to complete. Again, it's not my video, but that's approximately the amount of time that an uncomplicated phacoemulsification surgery takes. So this was phacoemulsification, modern way of removing cataracts. This table highlights the differences between extracapsular cataract extraction and phacoemulsification, which is shortened as phaco. This is something that's here because sometimes examiners tend to ask these things out of the blue. Not the most fairest thing, but hey, life's not fair. And these are not that difficult apart from one fact, which is anterior capsule removal techniques. I'll just show you the differences as to how they are different and why we do one over the other. But everything else is self-explanatory. We saw a smaller incision size in phacoemulsification, which obviously results in less astigmatism and quicker healing. Nucleus removal, as you saw, was with fragments. In extracap, all of it comes out. Intraocular lens, we implant a foldable, we implant rigid. Wound closure is by hydration, we don't use sutures, and this is by sutures, and the advantage is less astigmatism. Nucleus removal in IUL is basically a smaller wound. Anterior capsule removal, I'll just show you these two videos. So this is a video that we saw when we were seeing extracapsular cataract extraction. This is called the cystotome. It's a bend 1 cc needle which removes the anterior capsule. And as you see, as the surgeon is removing the capsule, he's not really careful about the edges. It's just a rough removal of the anterior capsule is just producing little nicks in it so that it can be cut and removed from the eye. It's not really being careful. And at that time, you really didn't need to be careful because all you needed was an opening through which you can express the nucleus out. Because remember, the nucleus is the largest structure within the lens. So it's just a very rough nicks in the anterior capsule, and then, you know, it's just removed. There we go. And if I can bring in a picture, this is how his removal or the edges of the capsulotomy were or are. They're very jagged. It's like an opened can with a manual instrument. That's why it was called can opener capsulotomy. As opposed to this picture that we'll see here, this is done with a forceps, and see how uniform or smooth the edges of the capsulotomy are. This is why it is called continuous curvilinear capsulorhexis, because it's done in one continuous motion, in the sense that the edge is continuous of the opening or the capsulotomy. Rhexis basically means to puncture. So if I can just bring those two pictures up again, this is rough, and see how smooth or continuous this is. It's like opening a can with a machine. Why is this important? Because this is a picture showing you the lens. This is the lens. This is the edge of the capsulotomy, which is rough, just like this, and you can see the cortex and the nucleus through it. If I put a phacoprobe here, what would happen is the phacoprobe can accidentally cause pressure on one of these tears, like here, not a tear, an edge of a capsulotomy. And what that pressure could do, extend this capsulotomy all the way back to the posterior capsule and cause a rent or a break in the posterior capsule, which is bad. Why is it bad? Because this is the posterior lens capsule and we need it because we put the lens on it. If this is gone, the first thing that would happen is nucleus and cortex, or both depending upon what's left in the eye, would fall in the vitreous. The second thing that would happen is, because these are foreign proteins to the eye, they would incite a very strong inflammatory reaction in the vitreous, vitritis. The third thing that would happen is you can't put a PCIOL because you have no support. So you can put an ACIOL. And finally, you have vitreous that can come into the anterior chamber, touch the cornea, cause corneal endothelium. We'll see how that happens. It can also raise the pressure because it can block the trabecular meshwork. We will talk more about it when we do angle closure. And it can also cause this endophthalmitis because vitreous is basically a lot of liquid proteins, which is a very good culture medium for bacteria, and it's right here where our wound was. So this is why we do continuous curvilinear capsulorhexis and phacoemulsification, so that even if I put the probe here, the pressure would be equally exerted around the edges of the capsulotomy, and there would be minimal danger of a tear happening, at least for this reason. There could be other reasons for the tear, but it won't happen because of rough edges of the capsulotomy. Just a few words about pediatric cataract surgery, and the most important question to answer is this cataract visually significant that you see in the pediatric age group? And most of them aren't. If they are visually significant, they need to be dealt with appropriately because they can lead to amblyopia, and we'll just touch upon that in a bit. The thing is, the question to ask then is, should we implant an intraocular lens? Well, if the child is less than 2 years of age, then no, because the eye is rapidly increasing in size, and it's very difficult to predict what power of intraocular lens to implant, i.e. which number of the lens to implant, because the eye can grow very rapidly, and it's very difficult to remove an intraocular lens that's been implanted. So the general consensus is, if you're doing surgery to a child who is less than 2 years of age, use spectacles or contact, and then perform a secondary intraocular lens procedure once the child is greater than 2 years of age. If your child is between 2 and 8 years of age, you do biometry and you implant 90% of the calculated power. And if you need a little bit of spectacles after that, you use it for as long as it is required. And this is the general consensus. There are studies that show that you can implant intraocular lenses even at age less than 2 years, but this is what the general consensus is right now. Let's talk about amblyopia. Amblyopia is of concern, especially in the preoperative period, and the surgery is getting delayed because the deprivation caused by the cataract, in the sense that it doesn't allow the light rays to reach the retina, this deprivation can cause vision deprivation or sensory amblyopia. We have talked about it when we were talking about the congenital type of cataracts when we were discussing classification system, the first one, onset. Post-operative anisometropic is also of concerns in a child who is younger than 2 years of age and has been corrected by spectacles. Remember that spectacles do magnify, even contact lenses magnify, but much less, just to some extent. So in order to sort of deal with both these types of amblyopia, post-operative, obviously we are sort of preempting, we do patching. And this is how we do patching. We have talked about patching when we talked about refractive errors, so it's the same principle here. The only difference is the cause of amblyopia. In refractive errors, it's only anisometropic. Here it's mostly vision deprivation, and if not appropriately managed, anisometropic after cataract surgery. What post-op medications do we give? Topical steroids are given to reduce inflammation, and they are a very important part of the management, but they're given for about 28 to 30 days. And it usually does not cause any harm in the sense that the cataract has already been removed, and the intraocular pressure usually does not rise if the steroid is given for this amount of duration. Topical antibiotics, they are said to be given as a prophylactic means of preventing infection. Honestly, if infection has to happen, it can happen even in presence of an antibiotic. It's mostly for your own self-satisfaction. Painkillers are usually avoided because they can mask symptoms of endophthalmitis. We'll see what endophthalmitis is when we talk about complications. Other medications may be required depending upon the surgical circumstances. For example, if you have a posterior capsular rent or corneal edema, we would require some more medications. We'll talk about it when we talk about those specific complications. These are the days that the patient is supposed to visit you back. On each of these visits, we examine the wound, that it's appropriately sealed, that the cornea is clear, the lens is in its place, and the anterior chamber, which basically tells you how much inflammation is in the eye, is quiet. You would expect some inflammation early in post-op day 1 and 7. By 14 and 28, the anterior chamber should be returning to as normal. And sorry, as time goes by, we slowly start tapering steroids, and maybe by 1.5 months or even 1 month into the surgery, the steroids are withdrawn. But they are always withdrawn by tapering. Finally, we started off from structure of the lens, then classification of the cataract, then presentation, management, principles of surgery, and now we are down to the last bit, which is the complications. Complications are very easy for any surgical procedure. They are divided into pre-op, per-op, and post-op. Pre-op is generally seen in local anesthesia, where the anesthesia is ineffective, and it's usually seen in drug abusers or smokers. And you can plan under alternate types of anesthesia, maybe MAC or general anesthesia if your local anesthesia is ineffective. Retrobulbar hemorrhage, we'll just talk about it in a bit, is something that used to be seen when we were using retrobulbar anesthesia, which is now not employed, so we don't see this. Per-op issues are iris prolapse, we'll see this. Posterior capsular rupture, also called a posterior capsular rent or a break, which is one of the most dreaded complications during surgery. And post-op are only corneal edema, posterior capsular opacification, which is quite interesting, and endophthalmitis, which is the worst type of infection, worst type of complication that you usually see in a patient who has undergone not only cataract surgery, but most ocular surgeries. So this is what a retrobulbar hemorrhage looks like, and this happens when you inadvertently hit a blood vessel as you are going blindly while injecting retrobulbar anesthesia. And this blood basically seeps in through the conjunctival tissue, and it just balloons it out. Since I do not see any clearing between the posterior part of the conjunctiva right here where my cursor is and the hemorrhage, I can assume this blood is coming from the orbit. And this can be dangerous because, as you can see here, this can kink and press on the optic nerve to damage it. This is a large retrobulbar hemorrhage as seen on a CT scan. So what we do is we admit the patient if not already admitted. Remember, most ocular surgeries can also be done as daycare procedures, so these patients are not already admitted. We wait for it to self-resolve, reduce intraocular pressure so that the eyeball is at least soft. If it doesn't resolve on its own, we need to drain it, and you usually require neurosurgical assistance for this. Actually, it's a neurosurgeon or an orbital surgeon that does this. This is per-op complication number 1. Remember, this was pre-op complication. This is per-op complication number 1, which is iris prolapse. Iris prolapse is out of your wound. This we saw in one of the videos as well, and we also saw how it was being reposited by a special instrument. This is because the iris is very flimsy, and if I can show you, the iris is as flimsy as this tissue paper. This is what the iris is. And since if you are doing too much instrument manipulation, the iris can come out with your instruments. If your wound is not properly constructed, your iris can come out. If the patient is squeezing the eye too much, the iris can come out of the wound. So this is one of the reasons for iris prolapse also, that you have a clip called the speculum that keeps the eye open. If it's pressing on the eyeball too much, it can also cause iris prolapse. So you either reduce manipulation, you release the pressure on the eye, and if the prolapse persists, call a more experienced surgeon to complete the surgery. And if you can't do that and it happened only in the incision and you have done nothing else, just close the wound, plan the surgery under a different type of anesthesia, because you probably have a patient who is trying to squeeze too much, causing this type of prolapse. This is what one of the worst per-operative complications, which is posterior capsular rent or a break. This happens because your instrument, generally a phaco tip, came too close to the posterior capsule and damaged it. Remember, these are ultrasound waves and they can damage whatever they strike. Our idea is to damage the nucleus, not the posterior capsule. And what that happens is, as we saw in the video where we were comparing capsulotomy with continuous curvilinear capsulorhexis, nuclear and cortical fragments can fall into the vitreous, causing a very severe inflammatory reaction. The vitreous can also come into the AC, cause a rise in pressure, corneal edema, as well as endophthalmitis. So all of these things can happen when you get a posterior capsular rent. So the idea is to keep your nerves about you, review the situation, clear as much vitreous as you can from the anterior chamber, close the wound, and send the patient to a vitreoretina surgeon if one is not available in your center. Because excessive manipulation by the surgeon, especially inexperienced, would cause more problems. This is what the vitreous does. It tends to come into the anterior chamber and forms a wick. Wick can sort of block the trabecular meshwork and also touch the cornea to cause corneal edema. We'll see how that happens in a bit. Now we are talking about post-operative complications, and the first one is wound leak. It's usually seen very early into the surgery, usually on day 1. It can be seen later as well if there was some trauma or the patient, rubs his or her eye too hard. And this is detected using something called the Siedel's test. We use a dye, fluorescent dye, to stain the tear film, and we see if that dye around the incision, the flow of the dye tells us if there is any aqueous coming out. The anterior chamber is going to be shallow because obviously the aqueous is draining too much out of the eye, and it's simply suture the wound if it was closed without suturing, which most of the time it is these days, or you can recraft your wound, that is, rehydrate it again. Corneal edema. Remember, we talked about corneal edema as a consequence of posterior capsular rent. This happens because of damage to corneal endothelium. Vitreous in anterior chamber can touch corneal endothelium and damage it. Too much instrument going in and out of the eye without the use of gel that we saw being used during cataract surgery, or inadequate use of gel rather, more appropriately, because everybody uses gel, can damage the corneal endothelium. And the corneal endothelium right here has a very special pump, which is a sodium potassium pump, which basically keeps the cornea relatively which keeps pumping fluid out of the cornea to keep it clear. If this endothelium is damaged, and this endothelial cells don't replicate, so whatever is lost is lost. Usually what happens is that the remaining cells sort of increase in size to take up the space, but if enough of them are damaged, that means that the cornea would start hydrating and you would get corneal edema. It could be localized, it could be diffuse depending upon the extent of damage. And what we need to do, the patient usually presents with visual loss after cataract surgery, or vision that did not improve after cataract surgery or actually worsened after cataract surgery. If it's off axis, for example, if it was here but not involving the pupillary area, patient might not even notice it and it just be picked up on routine scheduled post-op visits. What we want to do is to give enough time for the endothelium to recover as much as possible. So we reduce inflammation by giving steroids. We lower the eye pressure so that the production of aqueous reduces, so that the hydration level reduces. We give hypertonic saline to drag water out of the cornea. And if persistent, it might even require keratoplasty, because the entire purpose of cataract surgery was restoring vision, and this procedure failed to do it. So we need to do another procedure in order to, get the vision back. The third post-operative complication that we are talking about is posterior capsular opacification, and this is rather interesting. The patient usually comes in and says that my cataract has come back, my eye is white again. Well, it's not really a cataract, it's something called an after cataract, and we'll see how it develops. This happens because your posterior capsule after cataract surgery opacifies due to the remnant lens epithelial cells, which sort of transform themselves into fibroblast and start laying down opaque fibers. And this, to the patient, seems as if that the cataract has come back. This is not cataract. This is called after cataract, which is a layman term used to describe or explain this to your patients. The incidence of this varies between 5 and 50%, type of surgery, the type of intraocular lens implanted, and also the duration after surgery, i.e. how many years have passed since the surgery was done. And the presentation is usually a gradual painless loss of vision after visual recovery, which happened after cataract surgery, and slowly the vision starts deteriorating again. And it's usually after 6 months or more than 6 months. As time after cataract surgery passes, the incidence up to a certain point increases, usually 5 years. So how do we manage this? Obviously, if the posterior capsule has gone opaque, we need to create some spaces or opening in it, and that is done using a laser. And that laser is called a YAG laser. YAG stands for yttrium, aluminum, and garnet, and the procedure is called YAG capsulotomy. The effect that this laser produces is called photodisruption. We talked about another effect when we were talking about laser refractive surgery in context of refractive errors, and that effect was called photoablation. That was removing tissue in layers. This is called photodisruption, in which you are using plasma, which is a state of matter between liquid and gaseous states, and that plasma creates little bolts of lightning or explosion to simply evaporate a tissue from its place. We'll just see that in a video, and it exactly is. As soon as the laser hits, the tissue in that place simply disappears. So we just use this laser to sort of clean the posterior capsule when in fact we are poking holes in it, and we'll just see a video. It's very interesting. So this is how posterior capsular opacification appears. Ophthalmoscopic view, torch view, see how it has become all white, and we use laser to poke holes in it, and this is how it is done. Every time the laser, this is the targeting laser, and as you can see, when the laser is fired, it clears the capsule away from that area, simply evaporates it. And obviously, not every patient who gets cataract surgery done gets posterior capsular opacification. That is why it is a complication and not a routine thing you see. See how you fire a laser and opens the posterior capsule simply by evaporating it. The worst complication that you can get after cataract surgery, or one of the worst, is endophthalmitis. Endophthalmitis is defined as severe inflammation which can be sterile or infectious. If it's infectious, it's mostly bacterial within the eye. The sclera is not involved. If the sclera is involved, it is called panophthalmitis. This is the most devastating complication of any type of cataract surgery. Although with phacoemulsification, you get the minimum amount because your wound is small and the surgery is over quicker. And this is infectious when it comes to cataract surgery. Remember, it can be sterile as well. If it is within 2 weeks of cataract surgery, the infection, the source of the infection is somewhere at the time of the surgery. If it happens after 2 weeks, it is something that happened after surgery. Maybe the patient went home and got infected, or his wound got contaminated or something. It is very strongly associated with posterior capsular rent or a break. We have talked about that. Why is prolonged surgical time or excessive manipulation, because too many instruments going in and out carry a risk of carrying infection with them. Ditto for surgical time. If there was a pre-existing ocular infection that wasn't picked up, especially nasolacrimal system. Remember, when we were doing principles of surgery, we said that we need to look for any type of inflammation in the eye, around the eye as well, and in the lids as well, or your surgical field was contaminated. Symptoms are basically a lot of pain together with redness and blurred vision. A few of the patients don't complain of pain, but most of the time pain is there. I'll show you what the symptoms are the signs are in just a bit, but you have a red congested eye with pus in the anterior chamber, which is called a hypopyon, and corneal edema or haze because the sodium potassium pump is failing. the vision could be as bad as light perception vision. So this is what you see. You can see sutures implying this is extracapsular cataract extraction. This is the hypopyon. This is the conjunctiva that's sort of all congested, and this is a hazy cornea, which is because of loss of the sodium-potassium pump. And if at times it is very difficult to actually figure out, is it really endophthalmitis or just a very severe reaction within the anterior chamber? So you can do a B scan, and remember, endophthalmitis implies vitreous getting infected. And this is what you will see in case of endophthalmitis. You'll see vitreous opacities and membranes showing you that the vitreous is now full of cell and inflammatory exudation. This is a normal vitreous. It appears black on B scan. B scan, we have an entire video of B scan. We've already talked about B scan as a potential pre-operative investigation if the cataract is mature and we can't look at the retina to see if the retina is healthy, and surgery would result in return of some vision that's obstructed by the cataract. The prognosis for vision is really poor. Once the eye is infected from inside, it implies permanent visual loss of some sort. Management is again by intravitreal antibiotics after you have taken the sample of the vitreous for culture sensitivity. Empirical therapy is usually with vancomycin and ceftazidime, and since the infection is in the vitreous, we've already talked about why that is. The antibiotics are injected into the vitreous. Together with this, or under the cover of this, you can do vitrectomy, which is removal of vitreous. Remember, this is where the infection is, and we need to remove it. But we need the services of a VR surgeon who is willing to do this. Remember, you need to have disposable instrumentation for this, because whatever tubing or instruments you're using can become potentially contaminated with it. This is so intravitreal injections. We'll talk about intravitreal injections multiple times in ophthalmology for various reasons. One of the reasons is obviously infection within the eye, endophthalmitis. The safest way to inject into the eye is through pars plana. Pars plana is the flat part of the ciliary body. This is the ciliary body. It is made up of two parts, or it has two distinct parts. One is the parts with the folds, which is called pars plicata. This is the part that produces the aqueous humor and also has the zonules, which supports the lens. This is pars plana, which is the flatter part. It is has less vascularity. It has no retina photoreceptors over it, no retinal element over it, and it is a very safe way to enter the eye. When we do vitrectomy to put instruments in the eye, as you will see when we talk about retinal detachment or inject things into the eye, pars plana is the site that's selected for it. So this is, we use a clip, anesthetize the eye, use calipers to inject appropriately. We have an entire video of how intravitreal injections are done. You'll see them when we talk about retinal dystrophies and degeneration. So more information would be available to you there. But this is generally how it is done. Thank you very much for your time and attention. Please ask questions if you have any, and I'll see you in your next video.